There is a house somewhere in the middle of the American century. The year is 1952. The kitchen smells of percolated coffee and white bread toast, and through the window the street is quiet and pale in the early morning light. A woman sits at the table. She's not slept. The baby's in the next room, finally quiet after 3 hours of feeding and settling and crying and settling again, and she's listening to that quiet the way you listen to a sound that frightens you with all of yourself, with no part held back. Her hands are wrapped around a coffee cup that has gone cold. She has not noticed. Her name does not matter for our purposes because her name could be any name. She could be Eleanor or Dorothy or Ruth or Joan or Margaret or Helen. She is 26 years old. She has been married for 3 years to a man she met at a church social in 1948 and married quickly, as young people did in the years after the war, with the urgency of a generation that had seen what delay could cost and was not willing to wait. She has a husband who leaves for work at 7:30 every morning in a pressed suit and a hat that he touches at the brim when he says goodbye, a gesture he has performed every day for 3 years, and that she has watched 3 years of mornings. And she has a baby who is 6 weeks old, and she has this kitchen with its new refrigerator and its yellow curtains. She chose herself from the Sears catalogue, and she has these hands around this cold cup, and she has the feeling that has been building in her since the delivery room, the feeling she cannot name, the feeling she has told no one about. The feeling is not what she expected. Everyone told her what to expect. Her mother told her, on the phone from Pittsburgh, with the warmth of a woman who had done it twice, and who remembered only the version that had polished smooth with time. Her mother-in-law told her, with the particular authority of a woman who had raised 3 children and had opinions about every stage of it. Her friends who had gone before her told her, in the careful edited language that women use with one another when they sense that the full truth might be too much, or when they have told themselves the full truth is not the truth that lasts. They told her about the tiredness and the tenderness and the overwhelming love. They said she would look at that baby and feel something that rearranged everything she had ever known about herself. They said she would cry from happiness, actual tears of actual happiness, which was something she had not done since her wedding day, and perhaps before. They said her heart would expand in a way that hearts are not usually asked to expand, and that she would understand then for the first time what she was for. Not what she had been told she was for, but what she actually was for, understood from the inside out, obvious and complete. And she does feel something when she looks at the baby. She feels something. She feels something she cannot tell anyone. She feels a distance, wide and cold and absolutely silent, between herself and everything she is supposed to be feeling, not absence, distance. The feelings are there somewhere. She can sense them the way you can sense something in a dark room without being able to see it, but she cannot reach them, cannot access them, cannot translate them into the warmth and the certainty and the completion that everyone promised her she would feel. She feels a terror that has no single object, no point at which it can be named or addressed or reasoned with or resolved. It is there when she wakes up, and there when she tries to sleep, and there in the middle of feeding the baby, and there when she is washing dishes, and there when she's doing nothing at all. It is there without reason and without mercy and without any apparent intention of leaving. She feels sometimes that she's watching her own life from a great height, as though she has stepped outside her own body and is looking down at the woman in the kitchen with the cold coffee and the 6-week-old baby, and the husband who will leave at 7:30, and she cannot find her way back inside. The woman down there moves through her days performing every required action with something that resembles competence. She feeds the baby and changes the baby, and holds the baby when it cries, though the holding does not feel the way holding is supposed to feel. She makes the meals and washes the dishes and does the laundry, and keeps the house in the condition that a house with a new baby is supposed to be kept in, which is to say imperfectly but with visible effort. She does all of this while something essential in her stands apart from it, watching, unconnected, as though the performer and the performance have been separated by an event whose nature she does not understand and cannot explain, and whose cause she has decided, in the absence of any other available explanation, must be herself. She has not told her husband. She has told him she is tired, which is true but is not the whole truth, and he nods with the sympathy of a man who understands tiredness in the way that men who have not been through childbirth understand tiredness, which is to say that he understands something but not the specific thing. She has not told her mother, who would worry and come and stay, which would be both a help and an additional performance requirement that she does not have the resources to manage. She has not told the obstetrician who patted her hand at the 6-week appointment and said, "Everything looks just fine. You are healing beautifully. You must be so happy." She said yes. She said yes. "We are so happy. Thank you. He is wonderful." She did not tell him about the nights. She did not tell him about the thought she had last Tuesday at 3 a.m, the one she pushed away so fast that she's not entirely sure it happened. The thought that came while she was standing at the nursery window holding the baby in the dark. The thought about what it would mean if she were not here. Whether the baby would be better off with someone who could feel what she's supposed to be feeling. Whether her not feeling it was a harm she was doing to her child by simply continuing to exist in the condition she exists in. She does not know that what she's experiencing has a name. In 1952 she does not know, because almost no one knows, because the name does not yet exist in the form that would make it recognizable to her or to the people around her. She does not know that other women have sat in kitchens like this one, with coffee cups like this one, feeling this same distance between themselves and the life they are supposed to be grateful for. She does not know that what she has is something that can be treated, something that can be understood as a medical event rather than as a moral failure. What she knows is that something is wrong with her, what she has been taught to believe, by every authority she has ever trusted, by the culture she was raised in, and the medicine that was supposed to know these things, and the religion that organized her understanding of what she owed and to whom, is that motherhood is a woman's highest fulfillment, the destination toward which her entire nature has been pointing since the day she was born, and that a woman who does not feel fulfilled by it, who does not feel completed by it, who sits at the kitchen table at 6 a.m. with cold coffee and cannot find her way back to herself, is not suffering from an illness. She is suffering from a deficiency of character. She's failing at the most important thing she was ever asked to do. In a few days her husband will call the doctor, not because she has told him the truth, but because she has stopped being able to hide it. He will call the doctor because she's been crying without stopping for 2 days, and cannot explain why, or cannot explain in a way that makes sense to him, which amounts to the same thing. He will call the doctor because she has not eaten enough to maintain her weight, and she does not seem to care whether she eats or not. He will call the doctor because the baby's crying and she's sitting in the chair in the nursery looking at the crib and not responding to the crying, and he does not know what to do. The doctor will come to the house. He will ask her some questions. He will make some notes on a small pad. He will have a conversation with her husband in the hallway, in low tones that she can hear but cannot quite make out, while she sits on the edge of the bed and listens to the sound of her own breathing and tries to remember whether she's always been this frightened or whether that is also new. She will not come home for 2 years. If you enjoy listening to sleep documentary stories like this, subscribe. I post stories like this weekly. To understand what happened to women like her in the institutions of the 1950s, you have to understand first the world that sent them there. You have to understand the America that existed in the years after the Second World War, its particular combination of abundance and anxiety, its ferocious investment in a version of domestic life that had been constructed as much from ideology as from necessity, and the role it assigned to women with a specificity and intensity that had few historical precedents and whose consequences would take decades to fully understand. The war had done something to the country that the country had not entirely absorbed by 1952. It had taken men away and required women to fill the spaces they had left, in the factories and the offices and the farms and the fields, in roles that had been designated male by custom, rather than by any law of nature, and had demonstrated with the quiet efficiency of practical necessity that women could perform those roles with the same competence as the men who had previously occupied them. This was inconvenient. It was inconvenient for the factories who had to give the jobs back when the men came home. It was inconvenient for the political and cultural machinery that needed women to return to the domestic sphere and be grateful for the return. And it was particularly inconvenient for the cultural ideology that was attempting, in the years after the war, to reconstruct a version of femininity that had been decisively complicated by the practical evidence of the war years. The response to this inconvenience was not subtle. Beginning in the mid-1940s and accelerating through the 1950s, the culture produced with remarkable thoroughness and consistency a single narrative about the meaning of womanhood, and that narrative was domestic. The ideal woman of the 1950s was a wife and a mother, She lived in a house in the suburbs that her husband had bought with money he had earned at a job that kept him away from it for most of the day, and she managed that house with the combination of competence and devotion that made it a proper home, a word that carried an enormous weight of cultural meaning. She raised her children with a warmth and attentiveness that the previous generation, with its stricter and more distant parenting philosophies, was said to have insufficiently provided. She kept herself attractive for her husband and serene for her family and cheerful for her neighbours, and she found in the doing of all these things her full and sufficient fulfilment. This was not simply a cultural preference, though it was certainly that. It was an ideology with teeth. The ideology was delivered through every available channel simultaneously, through the women's magazines that appeared on every coffee table in America, through the advertisements that filled those magazines with images of smiling women at gleaming appliances, through the movies and the television programs that depicted domesticity as both the natural end of female aspiration and the source of female happiness, through the advice literature that proliferated in the post-war years with an enthusiasm that suggested the culture believed women required very specific guidance about what they were supposed to want and how they were supposed to feel. The psychoanalytic establishment contributed its own particular form of authority to this project. Freudian ideas, translated and popularized for the American mass market, provided a pseudo-medical scaffolding for what was essentially a political argument. The woman who was content in the domestic sphere was mentally healthy. The woman who was not content, who chafed against the limitations of the homemaker role, who wanted work outside the home, who found the raising of children insufficient as a full account of her intellectual and emotional life, was neurotic, maladjusted, suffering from penis envy or maternal ambivalence, or some other diagnostic category that converted her legitimate dissatisfaction into pathology. The key texts of 1950s popular psychology about women are remarkable to read today. They present as medical truth a series of value judgments about what women should want and be, and they treat the gap between those prescriptions and what women actually wanted and were as evidence of psychological disorder rather than ideological constraint. The woman who felt trapped in the domestic sphere was not responding rationally to an actual trap, according to this literature. She was projecting her own unresolved neurotic conflicts onto a situation that should have been providing her with everything she needed. Her unhappiness was a symptom of her pathology, not a reasonable response to her circumstances. Betty Friedan would identify this mechanism in 1963, in a book that began with the observation that women were suffering from a problem that had no name. The problem that she documented, the specific private unhappiness of educated women who had been told that domestic life was their destination and had arrived there to find it inadequate, was already present throughout the 1950s. Friedan called it the feminine mystique. But the women who were suffering from it in 1952 did not have her book, and they did not have her name for the problem, and they had been so thoroughly trained to understand their unhappiness as a personal failure rather than a structural one that most of them never arrived at the analysis she would eventually provide. What they had instead was the doctor. The family physician in 1950s America occupied a position of extraordinary authority in the lives of ordinary families, particularly in relation to women. He was the person women turned to when something was wrong, and he was the person who decided whether something actually was wrong, or whether the woman who believed something was wrong was simply insufficiently adjusted to the demands of her appropriate role. The family doctor's authority over women's health was nearly total, partly because medical knowledge was genuinely scarce, and partly because the cultural framework within which that medical knowledge operated insisted that the doctor knew better than the patient about almost everything, and that women specifically required guidance about their own emotional and physical states that they were not equipped to provide for themselves. When a woman presented to her doctor with symptoms that we would today recognize as postpartum depression, she was presenting within this framework. The symptoms she described, the persistent sadness, the inability to connect with her baby, the terror without an object, the sense of being outside her own life and unable to return to it, these were filtered through a clinical lens that had been ground by the prevailing assumptions about what women were and what they needed, and what was wrong with them when they were suffering. And in 1952, the most common interpretation of severe postpartum emotional disturbance was not depression. It was psychosis. It was a form of mental breakdown whose primary meaning, in the clinical literature and in the minds of the physicians who read that literature, was not a response to overwhelming hormonal and neurological change in the context of a socially isolating an emotionally demanding new role, but a fundamental derangement of the self, a break with reality whose proper treatment was institutional. The distance from the kitchen table to the psychiatric ward was shorter than it appeared, and it was travelled with a speed and a certainty that the woman at the table, with her cold coffee and her unnamed terror, had no reason to anticipate and no power to prevent. Her husband would make a phone call, a doctor would come, a decision would be made in a hallway in low voices between two men, and her life would change in a direction that no one, including the doctor who was trying to help her, fully understood. The post-war suburbs that produced the ideal domestic woman also produced, in their quiet and their conformity and their distance from the institutional supports of older urban communities, the particular conditions that made postpartum psychological crisis more likely and more difficult to address. The suburban house was a specific kind of isolation. It was isolation with a refrigerator and a washing machine and a television, and all the material evidence of abundance, but isolation nonetheless, a version of aloneness that was hard to name because it looked so much like the life you were supposed to want. The new mother of the 1950s was often far from her own mother, the nuclear family having been dispersed by the war and its economic aftermath to new cities and new suburbs where the husband's job had taken them. She was in a neighbourhood of strangers who were themselves trying to perform the required version of post-war domestic contentment. She had, in many cases, fewer social supports than any previous generation of new mothers had had, because the extended family networks and the neighbourhood communities that had historically provided those supports had been disrupted or left behind. She had, in their place, Dr. Spock's baby book and a subscription to Ladies' Home Journal, and a husband who came home at 6 expecting dinner, and who genuinely cared about her welfare but who had no vocabulary for what she was experiencing and no cultural permission to acknowledge its seriousness, because the culture that had shaped him had taught him that women who struggled with motherhood were maladjusted, and the last thing he wanted to believe was that his wife was maladjusted. So he watched. He watched her stop sleeping. He watched her stop eating. He watched her stop responding to the baby in the ways he expected her to respond. He watched the distance grow in her eyes, and when it grew large enough and stayed long enough that he could not continue not knowing what to do, he called the doctor. This is where the story properly begins, not with the illness, which had been building since before the delivery, but with the moment the illness became visible enough to enter the medical system, which was the moment it stopped being a private matter and became a clinical one, subject to the authority of a profession that had, in 1952, very specific ideas about what was wrong with women who felt the way she felt and what needed to be done about it. The America that this woman inhabited was also, and this matters, a country in the middle of a deep cultural anxiety about mental illness. The war had produced an epidemic of what was then called battle fatigue and is now called post-traumatic stress disorder, and the scale of that epidemic had forced psychiatry to expand its capacity and its visibility in ways that had complicated the public's relationship to mental illness. On one hand, the war had humanized mental breakdown to a degree, making it something that could happen to ordinary people under extreme stress rather than something that happened only to the fundamentally deranged. On the other hand, the expansion of psychiatric institutions and the proliferation of new and dramatic psychiatric treatments had given the field a technological confidence that outran its clinical understanding, particularly in relation to the treatments being applied to civilian patients who had not, after all, been through combat. The woman at the kitchen table was not a veteran. She had not survived combat. She had given birth to a baby 6 weeks ago, which was the thing she'd been told was the destination of her entire nature, and she was sitting in the kitchen of a house she was supposed to love in a life she was supposed to want, and she was not fine, and she did not know why, and she could not make it stop, and she could not make it stop, and she could not make it stop. In a few days the doctor would come, and the conversation that followed would set in motion a sequence of events that she did not choose, and could not reverse, guided by a medical system that was trying to help her with tools that were inadequate to what she needed and a framework that misunderstood what was happening to her at the most fundamental level. The lights are low now. The street outside is quiet. Somewhere in the house the baby has gone back to sleep. The woman at the table has set down her coffee cup. She's listening to something in the silence, something she cannot name, and the silence is very deep. Let us be precise about the legal and medical structure that allowed what happened to women like her to happen. Let us be precise because precision is the only adequate response to the specificity of what was done, and because the vagueness that has sometimes surrounded this history has served, perhaps inadvertently, the purpose of making it easier to misunderstand than it deserves to be. In the United States in the 1950s, the legal authority to commit a family member to a psychiatric institution rested primarily with the male head of household. This was not a feature of some states and not others. This was not a loophole or an anomaly. This was the law, built on centuries of legal tradition that had classified women as legally subordinate to their husbands in matters pertaining to their own medical care and mental status, a tradition that had its roots in the same common law coverture that had governed Regency England, and that had been modified but not abolished by the legal reforms of the intervening century. A husband in 1952 who believed his wife was mentally ill, or who was told by a physician that his wife was mentally ill, did not need his wife's agreement to have her admitted to a psychiatric facility. He needed two things. He needed a physician's certificate, a document signed by a medical doctor stating that in his professional judgment, the woman in question was of unsound mind and required institutional care. And he needed his own agreement to the admission, which in most states was sufficient to authorize the commitment of his wife to a state hospital or a private sanitarium for an initial period that could range from a few weeks to indefinitely, depending on the clinical judgment of the institution's staff and the husband's continued authorization of the stay. The woman herself was not required to consent. She was not required to be consulted in any meaningful sense. She could protest, she could refuse, she could insist that nothing was wrong, and all of these actions were routinely interpreted by the physicians and the hospital staff and the legal framework within which they operated, as further evidence of the disorder being treated rather than as a rational response to what was happening to her. The circularity of this was not invisible to everyone at the time, it was visible. It was commented on by a small number of legal theorists and reform-minded physicians. Their comments did not change the law. The practical process of a voluntary or involuntary commitment in the 1950s began with the family physician. This was the same man who came to the house when the children had ear infections, who administered the vaccinations and checked the blood pressure, and reassured the family that everything was fine when everything was fine, and that something needed to be done when something needed to be done. He was trusted specifically, and his trust was underwritten by the authority of his profession and his gender, and the particular relationship between American families of this era and the medical establishment that they believed was keeping them healthy. When a husband called this doctor and said that his wife was not right, not herself, that she had stopped sleeping and eating and responding, that she was crying or not crying when she should be crying, that she was sitting in a room not responding to the baby, the doctor would come. He would conduct an examination, which in 1952 consisted primarily of asking questions and observing responses, since the biochemical understanding of postpartum mood disorders had not yet been developed, and there were no blood tests or imaging studies that could reveal what was happening in the woman's brain. He would form a clinical judgment based on the answers to his questions and what he observed. What he observed, in many cases, was a woman who was severely depressed, who was experiencing what we would now identify as postpartum depression, in its moderate to severe form, with associated anxiety and sometimes intrusive thoughts, and sometimes a dissociative quality to her presentation that made it difficult to make contact with her in the normal social way. What he categorized, based on the diagnostic frameworks available to him in 1952, was something far more alarming than depression. He categorized what he saw as psychosis, or as a dangerous instability that warranted institutional management, because the diagnostic category of postpartum depression as a distinct condition with a specific presentation and a specific treatment did not yet exist in a form that was widely understood or applied. The first edition of the Diagnostic and Statistical Manual of Mental Disorders, published in 1952, the same year our woman sits at her kitchen table, included a category called involutional psychotic reaction and various forms of psychotic disorder, but did not include a specific diagnosis of postpartum depression. The DSM of 1952 was a document shaped by the same cultural assumptions as every other document of its era, and the cultural assumption it imported most completely was that women who broke down after childbirth were breaking down in the way that psychotic people break down, which is to say that their relationship with reality had become disordered, rather than that their neurochemistry had been disrupted, and their social circumstances had overwhelmed their capacity to cope. This diagnostic misclassification had direct consequences for treatment. A woman categorized as psychotic was a woman who required institutional management and the full range of institutional treatments, not because she was dangerous in any immediate sense, though sometimes she was, but because the category itself carried the assumption that her ordinary functioning had been so thoroughly disrupted that she could not be safely managed at home, could not be trusted to care for her child, could not be left to experience whatever was happening to her without the structured and controlled environment of a psychiatric facility. The physician would make his assessment, he would write his certificate, he would speak to the husband in low tones in the hallway, explaining what he believed was happening and what he recommended. In this conversation, the husband would learn that his wife needed to be admitted to the hospital for observation, for treatment, for care that could not be provided at home. He would learn that this was the responsible thing to do, the thing that a loving husband who wanted his wife to get well would agree to. He would sign the necessary papers which authorized the admission and which gave the institution the legal authority to hold her. She would not be present for this conversation. She would be in the room, or in the kitchen, or wherever she was when the two men stepped into the hallway, and she would hear the low murmur of voices but not the words, and she would know that something was being decided, and she would not be asked to participate in the decision. This was not an oversight. This was the structure. When the commitment was arranged, the transport to the institution was itself a carefully managed event. In some cases, the woman was told she was going to the hospital to rest, which was sometimes true and sometimes a deliberate softening of what was about to happen. In some cases, she was told nothing at all, or was told enough to get her into a car, and the full nature of what was happening became apparent only when the car arrived at a facility whose doors, once entered, locked from the inside. The state hospitals of 1950s America were large, underfunded, overcrowded institutions that had been built on a model developed in the 19th century, and that had been overwhelmed by the post-war expansion of psychiatric commitment. The private sanitariums were better resourced but still operating within the same diagnostic framework, the same treatment assumptions, and the same fundamental structure of authority in which the patient was the last person consulted about the conditions of her own care. Once inside these institutions, a woman's legal status changed in ways that had practical consequences for every aspect of her daily life. She had been admitted on her husband's authority. She would be released on a physician's authority, which would be exercised with reference to the husband's wishes and the institution's capacity and the clinical judgment of staff who were themselves products of the same framework that had diagnosed her. She could not simply decide she was well and leave. She could not contact a lawyer without the institution's cooperation. She could not refuse treatment except in the most limited circumstances. The institution had authority over her body and her time and her daily routine in ways that she had not agreed to and could not easily contest. Her husband, meanwhile, maintained legal authority over her financial affairs, her property, her household, and most significantly their child. The baby she had left at home was in the care of a woman her husband had engaged, a relative or a hired woman, and was legally and practically under her husband's control. She could not demand to see her child. She could not insist on information about the child's welfare. She was dependent entirely on her husband's goodwill for whatever contact she maintained with the life she had left, and her husband's goodwill was mediated by the physicians and the institution staff who could advise him on whether visits would be therapeutically helpful or counterproductive to her recovery. In a small but significant number of cases, the husband's decision to visit, or not to visit, or to bring the child, or not to bring the child, was influenced by factors that had nothing to do with his wife's therapeutic progress. It was influenced by his own distress at her illness, which was real and should be acknowledged. It was influenced by the inconvenience of her absence, which had disrupted the domestic life that had been organized around her competent management of it. It was influenced, in some cases, by the advice of relatives or the new woman who was managing the household in her absence, who had opinions about what was best for the family that did not always coincide with what was best for her, and it was influenced, in a number of cases, by dynamics in the marriage that had existed before her illness, and that the illness had complicated in ways that were difficult to navigate from inside a psychiatric institution. The husband who had committed his wife with the best of intentions and the genuine belief that he was doing the right thing was not necessarily a man who found the separation easy or who was indifferent to her welfare. Most of them were not monsters. Most of them were ordinary men who had been told by a physician they trusted that their wife was ill and needed institutional care, and who had agreed because that was what you did when a physician you trusted told you your wife was ill. They visited many of them, at the intervals the institution permitted. They brought candy or flowers or the small items the institution allowed. They sat across tables in visiting rooms and tried to have conversations that bridged the enormous distance between the life they were living and the life she was living, and they went home to children who asked where their mother was, and to houses that felt different without her in them. But their authority over her fate remained absolute throughout this process. They could agree to additional treatments she would not have chosen. They could authorize an indefinite extension of her stay. They could, in consultation with the physicians, make decisions about the course of her treatment that she had no formal power to contest. They were the legal and practical gatekeepers of her return to her own life, and whatever their personal motivations, the structure of the authority they held was the structure that the law had built, and that the medical establishment had operated within for so long that neither saw any reason to examine it. The woman at the kitchen table, in the days before the doctor came, was not aware of this structure in any detailed way. She knew, in the general way that women of her era knew such things, that husbands had authority and doctors had knowledge, and that when those two forms of authority agreed that something needed to happen, it happened. She had been raised in a world that organized itself this way, and she had no framework for imagining it otherwise, and she was far too frightened and far too exhausted to think clearly about anything at all. She was sitting at the table with the cold coffee, and the baby was quiet in the next room, and the street outside was pale in the early morning light, and she did not know what was going to happen to her. But something was going to happen. She could feel it coming in the way you can feel a storm coming before the clouds arrive, by the quality of the light and the stillness of the air, and the particular silence that settles before something changes. Something was going to happen, and she had no way to stop it. The psychiatric institutions of 1950s, America occupied a spectrum that ran from the vast and underfunded state hospitals at one end to the relatively comfortable private sanitariums at the other, with a range of general hospital psychiatric wards, veterans administration facilities, and religious institution-affiliated care homes filling the middle. What they shared, despite their differences in physical comfort and staffing ratios, and the social class of the patients they served, was the fundamental framework within which they operated. The same diagnostic assumptions, the same therapeutic approaches, the same structural relationship between the institution and the patient, and the same understanding of what it meant for a woman to be committed to their care. The state hospitals were the institutions that housed the largest number of patients, and they were, by the 1950s, in a condition of severe overcrowding that complicated every clinical intention and good faith effort to provide adequate care. The great state hospital system that had been built in the 19th century on the then progressive principle that the mentally ill deserved institutional care in dedicated facilities, rather than jails or poorhouses, had expanded enormously through the first half of the 20th century, and by 1955 the state hospital population of the United States was approximately 559,000 patients, a number that represented the peak of psychiatric institutionalization in American history. 559,000 people, in institutions built for far fewer, staffed at ratios that made any kind of individualized care functionally impossible, organized around the management of large populations of very different patients in the same physical space and under the same institutional rules. The chronic patients who had been in these hospitals for years or decades occupied the same wards as the acute patients who had arrived recently. The severely psychotic and the mildly depressed were managed under the same institutional authority, sometimes in the same rooms. For a woman admitted in the acute phase of a postpartum episode, the state hospital was a profound disorientation. She had been, until recently, a person living in a house with a husband and a baby, and yellow curtains she had chosen herself from the Sears catalogue. She had managed a household and had friends in the neighbourhood, and a life organised around the rhythms of domesticity and child-rearing, that the culture had told her was the destination of all female aspiration. And now she was here, in a building that smelled of disinfectant and old wool and the particular institutional odour that is the combination of many bodies in enclosed spaces with inadequate ventilation, wearing the clothes or the institutional garments that the ward allowed, in a room with other women whose histories and conditions she did not know, subject to a daily schedule that the institution had determined and that she had no authority to alter. The daily rhythm of the psychiatric ward in the 1950s was organised around meals, medication, supervised activities, and the treatments that the clinical staff had determined were appropriate. Wake up at 6 or 6:30. Breakfast in the dining room, where patients ate at long tables under the supervision of aides and nurses. Morning medications administered by the nurses, which by the late 1950s might include the new phenothiazine, antipsychotics, that had begun to transform psychiatric treatment, or might still be the sedatives and barbiturates that had preceded them, depending on the institution, the physician, and the particular clinical judgment applied to each patient. Supervised activities in the morning, which might include occupational therapy, which was taken seriously as a therapeutic intervention in some institutions and treated as busy work in others, or group therapy, which was being introduced in some hospitals in this period, or simply time in a day room with other patients and whatever diversions the institution provided. Afternoons followed a similar pattern: more supervised activity, more medication administration, visiting hours for the patients who had visitors, which not all of them did, and not all of those who did exercised. The visiting rooms of 1950s state hospitals were rooms that people remember with specificity even decades later. The particular combination of institutional furniture and fluorescent lighting, and the awkward self-consciousness of visits conducted in public spaces under the implicit observation of staff, the conversations that were shaped by what it was possible to say in that environment and what it was not, the goodbyes that were different from ordinary goodbyes in a way that neither party was equipped to fully articulate. Evenings were the most difficult time in the institutions, and the clinical staff knew this, and the patients knew this, and the night shift aides who managed the wards after the day staff had gone home knew this. The darkness brought its own particular weight to the institutional experience, a weight that pressed differently on different patients, but pressed on all of them. The woman who had been in the state hospital for 3 weeks, who had not held her baby in 3 weeks, who had received no letter from her husband in 7 days, who did not know when she would be discharged because no one had told her, and she had not found the courage or the opportunity to ask, lay in her bed in the quiet ward and listened to the sounds of the institution at night. The distant crying of another patient, the squeak of the aide's shoes in the corridor, the institutional sounds of a building that never fully slept, and she lay in the dark with the terror that had brought her here, which had not yet been adequately addressed, and tried to find her way through the night to the morning. The private sanitariums were physically different from the state hospitals, in ways that mattered enormously to the families who could afford them and that should not be minimised. They were smaller. They had better staffing ratios. The rooms were private or semi-private rather than open ward. The food was better. The grounds were often pleasant, with lawns and gardens that patients could use at supervised times, and this physical pleasantness was not nothing. The therapeutic environment had meaning, and the meaning of a room with a window and a garden outside it was different from the meaning of an overcrowded ward in a state hospital that had not been adequately funded since the Depression. But the private sanitariums operated within the same diagnostic framework and the same therapeutic assumptions as the state hospitals. The woman admitted to a pleasant New England sanitarium by a husband who could afford the fees was not in a fundamentally different clinical situation than the woman in the state hospital. She was still being treated for what her physicians classified as a psychotic or severe neurotic disorder. She was still receiving the treatments that 1950s psychiatry offered for those conditions. She was still subject to the institutional authority structure that had admitted her on her husband's authorization and would release her on the clinical judgment of staff acting in consultation with that same husband. The gardens were nicer. The underlying situation was the same. The nursing staff of these institutions occupied a position that was simultaneously essential to patient welfare and structurally constrained in their ability to exercise clinical judgment. The nursing profession in the 1950s was organised around a model of hierarchy that placed the physician's authority above everything, and psychiatric nursing in this period was particularly constrained because the specialty was still developing its own professional identity and its own therapeutic framework separate from the physician-directed model of care. The nurses knew the patients in ways that the physicians did not. They spent their working hours in the wards. They saw the patients at their best and their worst. They had the daily conversations that allowed them to assess emotional progress in ways that the physician's weekly or twice-weekly clinical interview could not provide. Some of these nurses were remarkable people who found within the institutional constraints real ways to help, who sat with patients in the difficult evenings, who arranged the small comforts that the institution permitted, who wrote down what patients said when patients needed someone to hear them and there was no one else. The occupational therapists, who had developed a more patient-centered philosophy of care in their training, often had relationships with patients that were among the most therapeutically valuable that the institution provided, though the institutional hierarchy did not always reflect this in the authority granted to their assessments. But the structural constraints on what nurses and allied health staff could do were real and constant. They could not release patients. They could not alter treatment plans without physician authorization. They could not, in most cases, formally communicate patients' distress or objections to the clinical and administrative decision-making process in ways that would reliably influence it. They could advocate informally, and good nurses did, but the formal authority remained with the physicians and the institution's administration, and the physicians and the administration remained shaped by the assumptions of their era about what was wrong with these women and what needed to be done about it. The patients themselves formed their own social world inside the institutions, and that world was not nothing. Women who had been admitted under similar circumstances found one another, and the recognition that passed between them in the dining room or the day room or the corridor had its own particular meaning. The recognition of people who understood something about each other that did not need to be explained, because the explanation was the place they were both in and the way they had both arrived there. Some of the friendships formed in these institutions were lasting ones, maintained after discharge through letters and occasional visits, the particular bond of women who had been through something together that they could not fully discuss with people who had not been there. The mail was a critical lifeline and a critical vulnerability. Letters from home arrived, when they arrived, with a weight that exceeded their physical dimensions. A letter from a husband saying that the baby was fine and that he hoped she was feeling better was a letter that could be read 10 times in a single afternoon and still yield something new, some reassurance or some anxiety, on the 11th reading. A letter that did not come from a husband who had stopped writing or had never written, or who was waiting for something in her condition that had not yet arrived, was an absence that pressed on the day in which it was expected and did not come with a specific and grinding weight. Some institutions read the mail before distributing it, not as a systematic surveillance program in most cases, but as a clinical precaution, an attempt to identify letters that might disturb the patient's progress. The practice was not uncommon and was considered clinically defensible by the physicians who authorized it. Its effect on the patients who discovered it, or who suspected it, was to add another layer to the already comprehensive institutional management of their reality. The sense that even the communications from outside were being mediated by the institution's judgment about what was good for them, which was a judgment the institution had not always earned the right to make. Phone calls were controlled in most institutions, available only at scheduled times and sometimes only with staff supervision, which meant that private communication with family members was constrained in ways that made it difficult to have the kinds of honest conversations about how she was actually doing and what she actually needed that might have been most therapeutically useful. The conversations she had with her husband during supervised phone calls were conversations conducted under the implicit knowledge that they were not fully private, which shaped what she said and what she did not say, and which sometimes meant that the information flowing between the institution and the family was managed in the institution's interest rather than the patient's. This is the world she entered when the car pulled up to the facility. Not a world of monsters, not a world of deliberate cruelty in most cases, but a world shaped by assumptions that were wrong in fundamental ways, organized by authority structures that had no obligation to take her experience seriously, and dedicated to the treatment of something it did not correctly understand, using methods whose adequacy it had not properly evaluated. She was, in the clinical record, a patient. She was, in her own experience, a person who had been removed from her life without her consent, who was in a building she had not chosen, being treated for a condition she had not been consulted about, separated from her baby by a structure that did not require it to consider what that separation meant for either of them. The lights in the ward dimmed at 10 o'clock. In the corridor, the night shift aide made her rounds. Somewhere a long way from here, in a house with yellow curtains, a baby slept in a crib beside a bed that was empty on one side. The treatments applied to women in psychiatric institutions in the 1950s were products of the 2 preceding decades, a period of remarkable therapeutic invention in psychiatry that had been driven less by scientific understanding of the conditions being treated and more by the clinical desperation of physicians who had nothing else to offer, and the discovery that certain extreme interventions produced observable changes in the behavior and presentation of patients who had previously been unresponsive to anything the profession could provide. Electroconvulsive therapy, known then as electroshock treatment, and by various abbreviations that suggested the clinical neutrality the field was attempting to project, had been introduced in 1938 by Ugo Cerletti and Lucio Bini in Italy, building on earlier convulsive therapies that had used chemical means to induce seizures in the belief that there was an inverse relationship between epilepsy and schizophrenia, and that inducing something resembling the former might reduce the severity of the latter. The logic of this was not sound in any rigorously scientific sense, but the intervention produced effects that physicians found clinically meaningful, and by the 1940s, electroconvulsive therapy had become one of the standard treatments in the psychiatric armamentarium on both sides of the Atlantic. By the 1950s, electroconvulsive therapy was being administered to patients in psychiatric institutions across the United States, with a frequency and a range of indications that would be considered extraordinary by the standards of later decades. It was used for schizophrenia, for severe depression, for what was classified as psychosis of various kinds, for patients who were acutely suicidal, and, significantly, for patients who had been admitted following what was diagnosed as a postpartum psychotic episode. The diagnostic category of postpartum psychosis, which was the classification most commonly applied to women with severe postpartum presentations in this period, carried a strong clinical recommendation for electroconvulsive therapy in the literature and in the practice of psychiatrists who were applying that literature. The experience of receiving electroconvulsive therapy in the early 1950s was different from the experience of receiving it today in ways that are not trivial. By the late 1950s and into the 1960s, the procedure was being modified through the introduction of muscle relaxants and anesthesia that eliminated the convulsion itself and the fracture risk that had accompanied the grand mal seizures produced by earlier protocols. But in the early years of the decade, electroconvulsive therapy was often administered without these modifications, or with only partial modification, which meant that the patient was awake or semi-conscious during the preparation for the treatment, that the current was applied directly, and that the resulting seizure was a physical event. The memory disruption produced by electroconvulsive therapy in this form was not a side effect that was considered minor by the patients who experienced it. Memory loss was common, sometimes extensive, and often not fully reversible. The specific nature of the memory impairment varied from patient to patient, but the pattern that appeared most frequently was a disruption of both the recent memory of events just before and during the course of treatment, and, in some cases, a more significant disruption of autobiographical memory that left patients uncertain about specific periods of their past. For a woman who had been admitted following a postpartum episode, the disruption of memory in this period had a specific significance. It disrupted memory of her baby's early months, of her marriage, of events and relationships and experiences that were not abstract historical facts, but were the fabric of her daily life and her sense of who she was. The women who received electroconvulsive therapy in 1950s institutions, and who later wrote about the experience, described it in terms that the clinical record does not. Sylvia Plath, who received electroconvulsive therapy at McLean Hospital in the early 1950s after a suicide attempt, wrote about the experience in the bell jar with an immediacy that medical documentation could not provide. She wrote about the anticipation, and the table, and the current, and waking afterward not knowing where she was and what she wrote, was not the experience of a person who had been helped in the most straightforward sense of the word, though she was eventually helped by the therapy under different conditions. What she wrote was the experience of a person who had been taken somewhere against her understanding, and returned changed in ways she had not been asked about. Insulin coma therapy was another treatment widely used in the 1950s psychiatric institutions for patients classified as psychotic, including women with postpartum psychotic presentations. The therapy, developed by Manfred Sackel in the 1930s and widely adopted throughout the 1940s and into the 1950s, involved the administration of large doses of insulin to induce a hypoglycemic coma, which was then reversed with glucose after a period that could range from an hour to several hours. A typical course of insulin coma therapy ran to weeks, with treatments administered daily or several times per week, and each treatment involved the patient going into a coma state and being brought out of it, a process that required continuous monitoring and that carried genuine medical risks including prolonged coma and, in a small number of cases, death. The therapeutic rationale for insulin coma therapy was never clearly established, and by the late 1950s the practice was declining as controlled studies began to suggest that the observed improvements in patient condition were no greater than those produced by other interventions, including the simple passage of time in a structured institutional environment. But through the early and middle 1950s, insulin coma therapy remained a standard treatment in many institutions, and women admitted with postpartum psychotic diagnoses could receive it as part of their treatment course alongside or instead of electroconvulsive therapy, depending on the clinical judgment of their treating physicians and the treatment philosophy of the institution. The experience of insulin coma therapy from the patient's perspective is documented in relatively few accounts, because the memory disruption associated with it was significant, and because the period of treatment was, by definition, a period of repeated unconsciousness that left few experiential traces available for later recollection. What women reported afterward was primarily the experience of the recovery period, the disorientation and weakness and confusion of returning to consciousness in a clinical environment after an episode of induced coma, a process that was apparently distressing even when the staff managing it were skilled and attentive and operating in good faith. Hydrotherapy, the therapeutic use of water in various forms, was a third major physical treatment used in psychiatric institutions in this period, and it occupied a different register from electroconvulsive therapy and insulin coma therapy because it was older, less dramatic, and more widely regarded as a supportive rather than a primary intervention. The continuous bath, in which a patient lay in a tub of water at a controlled temperature for extended periods, sometimes hours, had been used in American psychiatric institutions since the late 19th century, and in the 1950s it remained in use in many facilities as a treatment for agitation and anxiety, which were common features of the postpartum presentations that these women arrived with. The continuous bath was not a violent treatment. It was, in fact, often described by patients who experienced it in comparatively neutral or mildly positive terms as a treatment that produced a calming effect that other available interventions at the time could not match without the side effect burden of the available sedative medications. This does not mean it was an adequate treatment for what these women were experiencing. A woman in a hydrotherapy tub for several hours was not receiving the psychotherapeutic attention that would have been most clinically appropriate for her condition, because psychotherapy in this period was not widely applied to women classified as psychotic, who were considered poor candidates for insight-oriented work until their acute symptoms had been sufficiently reduced by physical means. Chlorpromazine, marketed under the name Thorazine in the United States beginning in 1954, changed the landscape of psychiatric treatment in ways that were genuinely significant, though the change was more complicated than the triumphalist narrative that sometimes surrounds it suggests. Thorazine and the class of antipsychotic medications that followed it were effective in reducing the most acute symptoms of psychosis: the hallucinations, the severe agitation, the disorganized thought processes that made it impossible for patients to function in ordinary social contexts. For patients who were genuinely psychotic, these medications represented a meaningful advance in what psychiatry could offer. But Thorazine was also prescribed to a very broad range of psychiatric patients in the years following its introduction, including to women whose primary condition was not psychosis, but severe depression with anxiety, which was a better description of what many postpartum patients were actually experiencing. In these patients, the antipsychotic effects of the medication were not the relevant therapeutic mechanism, and the sedation it produced, while it reduced visible agitation, also reduced the patient's capacity for the kind of engagement with her environment and her relationships that would have been most valuable to her recovery. The calmed, sedated woman was easier to manage in the ward. Whether she was better for the sedation in any therapeutic sense was a question that the clinical practice of the era was not reliably asking. Beyond these primary physical treatments, women in 1950s psychiatric institutions also received occupational therapy, which had its own history and its own philosophy, one that was in several important respects more genuinely patient-centered than the physician-directed physical treatment model. Occupational therapy had developed from the moral treatment movement of the 19th century, which had emphasized the therapeutic value of meaningful activity and work in the recovery of psychiatric patients, and the occupational therapists of the 1950s were, as a professional group, often more attuned to the patient as a person with individual interests and capacities than were the physicians who directed the overall treatment plan. The occupational therapy sessions in which women made ceramics or wove fabric or arranged flowers or learned shorthand were not, in the view of many patients, the most important part of their institutional experience, but they were often the part of it that felt most human, most connected to who they had been before the illness and who they hoped to be after it. The occupational therapist who noticed that one patient had a facility with colour and another with words, and who adjusted the activities accordingly, was practicing a form of individualised care that the physician's clinical interview rarely matched. None of this was adequate, not the electroconvulsive therapy, which addressed the symptoms of acute disturbance without addressing its causes, not the insulin coma therapy, whose therapeutic mechanism remained unclear and whose risks were real, not the medications, which sedated rather than healed, not the occupational therapy, which was genuinely helpful within its scope but whose scope was limited. None of it was adequate to what these women were actually experiencing, which was the intersection of a hormonal and neurological crisis with an overwhelmingly demanding social role in the context of a culture that had no language for the crisis and would not have acknowledged the role's demands even if it had found that language. The adequacy failure was structural, not personal. The physicians who administered these treatments were not sadists or fools. The nurses who managed the wards were not indifferent. The institutions, even the overcrowded and underfunded state hospitals, were staffed largely by people who were trying to help and who were using the best available tools for the job, as the professional consensus of their era defined those tools. The inadequacy was in the framework, in the diagnostic misclassification that turned postpartum depression into psychosis, in the cultural assumptions that made it impossible to see what was actually wrong and what was actually needed, in the treatment philosophy that addressed the visible symptoms of distress without attending to the underlying condition, in the legal structure that removed the patient's authority over her own care at the moment she most needed to exercise it. She lay in the ward at night after a treatment, and the ward was quiet, and through the window the sky had the particular pale quality of very early morning, the hour before the light decides to arrive, and she was not certain what day it was, and she was not certain what she'd been thinking about before she fell asleep, and she would not be certain tomorrow either. There were things she could not reach in her own memory, things that had been there before and were not there now, and in their place was the particular blankness that electroconvulsive therapy left behind, which was not nothing, and was not something, and was different from anything she had been told to expect. She thought about the baby. She was almost always thinking about the baby, in the way that the thought of the baby had become the organising structure of her consciousness in this place, the reference point she returned to as the evidence that there was still something to return to. She did not know tonight whether she had been here 3 weeks or 5 weeks, because the days had begun to flow together in the particular institutional way, and the treatments had disrupted her sense of the sequence of events. She knew the baby was somewhere, being cared for by someone, and she knew that she loved the baby, or had loved the baby, or would love the baby when she was well enough to love anything again, and she held on to that knowledge in the dark as the only map available to her in a place where all the other landmarks had been removed. The ward breathed around her. The night shift aide made her rounds. Outside, the pale sky was beginning very slowly to change. There were husbands who visited every permitted day, and husbands who visited once a month, and husbands who did not visit at all, and the range between these was not simply a range of affection, but a range of what men in 1950s America were equipped to do with the specific kind of helplessness that a wife in a psychiatric institution produced in them. The cultural script for American men of the post-war generation was a script that had very little room for helplessness. The war had required a particular kind of masculinity that was about competence and action, and solving the problem in front of you, and moving forward without excessive dwelling on what could not be changed. And the men who came home from it had carried that requirement into their civilian lives, into the suburbs and the offices and the family structures that the 1950s built around them. They were the providers. They were the decision-makers. They were the people who fixed things when things needed to be fixed, and when things could not be fixed, they were the people who arranged for the appropriate experts to do the fixing. When a wife had a psychiatric breakdown, the appropriate expert was the physician, and the appropriate arrangement was the institutional one, and the husband had made the arrangement and the appropriate experts were doing the fixing, and there was, from the husband's perspective, nothing further for him to do except wait for the fixing to be complete. This is not an entirely uncharitable reading of the situation. The husband had acted within the system that his culture had built, and the system told him that he had done the right things, called the doctor, authorized the admission, paid the bills, arranged for the care of the child. There was nothing more the system required of him, and so he waited. But the waiting had its own texture and its own complications that did not always serve his wife's interests or his own. The man who did not visit regularly was often a man who was afraid of the institution, afraid of what he would see there, afraid of the version of his wife he would encounter across the visiting room table, which was not the version he had married and not the version he was waiting to get back. The psychiatric institution in 1950s America was a frightening place to visit even if you were not the patient, and the men who found reasons not to go were not all men who did not care. Some of them were men who cared so much that the caring had taken a form that looked, from the outside, like its opposite. The man who did visit carried the burden of the visiting room in a way he could not easily discuss with anyone. He sat across the table from his wife and looked at her face and tried to find in it the face he knew, and sometimes he found it, and sometimes he did not. And the difference between those two experiences was a difference he had no vocabulary for and no one to talk to about. He drove home afterward through streets that were ordinary in their ordinariness, past houses where other families were having ordinary evenings, and he went into his house and paid the woman who was caring for his child, and put the child to bed and sat alone in the kitchen, that was his wife's kitchen, and tried to think about something other than the visiting room table, and the expression on her face when he said goodbye. The men who performed their authority during this period did so within a structure they had not designed, and whose full implications they did not always understand. A husband who agreed, on the advice of the treating physician, to extend his wife's hospitalization for an additional month was not necessarily a man who wanted her confined. He was a man who trusted the physician's judgment, because that was what the culture required of him, and the physician had told him that another month was what his wife needed. And who was he to argue with the physician about what his wife needed when he had put her in the physician's care precisely because he was not equipped to judge these things himself? But his agreement was not a neutral act. It had consequences. It extended the separation from the baby. It extended the institutional management of her daily life. It extended the period during which she had no authority over her own situation and no reliable information about what was happening in her home. If she had been ready to come home sooner than the physician thought, if her apparent progress had been sufficient for a careful discharge plan with community follow-up, the husband's agreement to the extension foreclosed that possibility. And the husband was not asked to consider this, because the structure did not ask him to. It asked him to trust the physician. It did not ask him to advocate for his wife's preferences, because her preferences were not formally part of the clinical or legal calculus. There were husbands who did advocate, who said to the physician at some point, "She seems well enough to me. I want her home. I think she needs to be home with the baby and I am prepared to support her there." Some of these husbands were right, and the discharge that followed allowed for a recovery that the continued institutionalization would have complicated. Some of them were wrong, in the sense that the discharge happened before the acute phase of the illness was fully resolved and the woman came home to a situation that overwhelmed her fragile stability, and she returned to the institution within weeks, which was a cycle that some women went through more than once. The domestic arrangements that the husband made in his wife's absence were arrangements that had consequences beyond the immediate period of her hospitalization. The woman who came in to care for the child was a woman who developed her own relationship with that child during the weeks and months of the mother's absence. And the child who had known the substitute caregiver as the primary care figure for the formative months of its early life would require time and patience and a rebuilding of the attachment that had been interrupted. The husband who had managed the household in his wife's absence had made accommodations and developed routines that had become, by the time of her return, the household's established way of doing things, and the return of the woman who had originally managed it was a disruption of those routines as much as it was a restoration of the household to its prior state. The woman who came home after weeks or months in a psychiatric institution came home to a household that had organized itself around her absence, and the reorganization had not waited for her to participate. The child she had left at 6 weeks old was now 3 months old, or 6 months old, or a year old, and the gap in her direct relationship with that child was a gap that she had not been present to fill and could not simply resume as though it had not occurred. The husband who had managed the household was not always a man who handed it back readily. partly because handing it back meant relinquishing control he had exercised for months, and partly because there was, sometimes, a residual uncertainty about her stability that expressed itself as a reluctance to restore her full authority over the domestic sphere she was supposed to inhabit. This is not to make the husbands into villains. The most accurate accounting is more complicated and less satisfying than a villain would provide. Most of them were doing what the culture equipped them to do, operating within a structure they had inherited and had not been invited to examine, trying to navigate a situation that had no good roadmap and that the available culture offered no honest language for. The ones who were kind and patient and present, and who managed the period of their wife's illness with grace, and who welcomed her home without conditions, and who rebuilt their marriage and their family with her, are part of this story too. The ones who were not those things are also part of this story. Both are part of the same story, which is the story of what the structure made possible, and what it made inevitable, and what fell into the gap between a man's good intentions and the institutional reality his wife was living in. The legal fact of his authority over her fate was not a fact that any individual husband invented. He was operating within a legal and cultural framework that preceded him, and that would be changed, eventually, by the feminist legal reform movement of the 1960s and 1970s, which established the principle that patients of both sexes had the right to refuse treatment and to participate in decisions about their own care, which established the right to legal representation in commitment proceedings, which eventually dismantled most of the legal infrastructure that had made the 1950s commitment process possible. These reforms came. They came slowly and incompletely, and they have never been fully consolidated, but they came, and their coming represents one of the real and hard-won advances in the rights of psychiatric patients in the 20th century. But in 1952 they had not come yet. In 1952 her fate was in his hands and in the hands of the physician he trusted, and neither of those pairs of hands fully understood what they held. Before we can understand how the women of the 1950s were treated, we have to understand what went unnamed and how long the naming took, and what the absence of the name cost in the centuries before its partial arrival. The condition we now call postpartum depression has been observed by physicians and recorded in medical literature for more than 2,000 years, in fragmentary and imprecise forms, under a shifting series of names that each revealed more about the assumptions of the era that produced them than about the condition being described. That this history is so long and so poorly resolved is itself part of the story. It tells us something about the relationship between medicine and female experience that such a common and consequential condition remained so thoroughly unnamed for so many centuries. Hippocrates, writing in ancient Greece in the 4th century before the Common Era, described cases of what appears to be postpartum mental disturbance in terms that modern readers can recognize even through the distortion of 2.5 millennia of translation and reinterpretation. He attributed the disturbance to blood flowing to the brain, a humoral explanation that located the cause in the body, but misidentified its mechanism in ways that would not be corrected for more than 2,000 years. What is notable about the Hippocratic account is not its accuracy, which is limited, but the fact that it is there at all. The observation that women could become seriously mentally ill after childbirth, that this was a recognizable and recurring pattern, and that it deserved clinical attention. Between the Greek medical writers and the early modern period, the condition appeared and disappeared from the medical literature with the irregularity of something that was being noticed by individual practitioners without ever being organized into a stable clinical category. Medieval medical writers addressed it in the context of uterine theory, attributing the mental disturbance to malign vapors arising from the womb, an explanation that again located the cause in the female body but organized it around the reproductive organs in a way that was both anatomically specific and theoretically useless. The treatment implications of this theory, which might involve purgatives or aromatic substances designed to redirect the vapors, were not effective. The 17th century produced the first English-language accounts of postpartum mental disturbance that are detailed enough to allow confident retrospective diagnosis. The physician Thomas Willis, writing in the 1660s and 1670s, described cases of women who became seriously disturbed after childbirth with a clinical precision that is striking in the context of its era, noting both the timing of the onset and the specific character of the symptoms in terms that suggest genuine clinical observation rather than theoretical speculation. But Willis's accounts remained isolated observations in a field that had not yet developed the conceptual infrastructure for transforming individual case observations into a general clinical category. Through the 18th and 19th centuries, the condition was variously described as puerperal insanity, puerperal mania, lactational insanity, and several other formulations that combined the Latin term for childbed with the standard psychiatric categories of the era. These terms represented a genuine clinical advance in that they recognized the postpartum onset of the condition as clinically significant, distinguishing it from other forms of mental illness that occurred outside the reproductive context. The doctors who used them were not wrong to think that the timing mattered. They were working towards something. The problem with puerperal insanity as a clinical category was the same problem that would persist into the 1950s and that would not be fully resolved until the latter decades of the 20th century. The category was too broad, too defined by its timing rather than by a coherent understanding of its mechanism, and too thoroughly shaped by the cultural assumptions of its era about what female mental disturbance meant and where it came from. In 19th century psychiatric practice, puerperal insanity was treated primarily in the asylum, which was where all serious mental illness was treated, and the treatments available in the Victorian asylum were the treatments of Victorian psychiatry: moral management in its better forms, mechanical restraint in its worse ones, the early use of sedative medications including chloral hydrate and bromides, and eventually the barbiturates, and the general principle of removing the disturbed woman from her home environment to a controlled institutional one, where the stimulations that were thought to aggravate the condition could be minimized. The Victorian medical literature on puerperal insanity is large and detailed and reveals, in its detail, the assumptions that shaped it. The case studies published in Victorian psychiatric journals are often remarkably sympathetic at the individual level, attentive to the specific circumstances of the women being described in ways that the clinical literature of the 1950s did not always match. But the framework within which this sympathy operated was a framework that understood puerperal insanity as a fundamentally female vulnerability, arising from the peculiar instability of the female reproductive system and the particular susceptibility of the female constitution to the demands of childbearing. This was not a framework that inquired into the social conditions of the women it described: the poverty, the inadequate nutrition, the lack of domestic support, the previous children born in quick succession, the domestic violence that the case notes sometimes mentioned in passing, without appearing to consider its relevance to the mental disturbance they were documenting. The 20th century brought a series of diagnostic reorganizations that both advanced and complicated the understanding of postpartum mental illness. The early 20th century psychoanalytic movement contributed to the literature a set of case studies and theoretical formulations about maternal ambivalence and the psychological dimensions of the postpartum transition that were, in their attention to the emotional and psychological experience of new mothers, genuinely more sophisticated than the Victorian humoral accounts. But psychoanalytic theory also contributed the framework of neurosis and the related conviction that postpartum mental disturbance was fundamentally a product of the woman's unconscious conflicts about motherhood and femininity, a framework that had the effect of making the illness the woman's fault at a deeper level than the surface failure of character that popular culture identified. The first diagnostic and statistical manual of mental disorders, published in 1952 by the American Psychiatric Association, represented the first systematic attempt to organize American psychiatric diagnosis into a coherent and standardized classification system. It was a document produced by a profession in transition, attempting to consolidate the competing diagnostic vocabularies of European psychiatry, American psychoanalysis, and the practical clinical experience of military psychiatry during the Second World War into a usable reference for practicing clinicians. The DSM-1 did not include a specific diagnosis for postpartum depression. It did not include a specific diagnosis for postpartum psychosis as a distinct category separate from other psychotic disorders. What it offered for the women who arrived in psychiatric institutions following childbirth was a set of general categories, including the various psychotic reactions and neurotic reactions that could be applied to their presentations based on the severity and character of their symptoms without reference to the postpartum context as clinically specific or diagnostically relevant. This was not a neutral omission. The absence of a specific postpartum category in the DSM-1 and in subsequent editions through DSM-3 meant that the physicians who were treating women with postpartum psychiatric presentations were classifying them under general psychiatric categories that did not capture the specificity of their condition. that did not generate treatment recommendations appropriate to their actual situation, and that did not communicate to subsequent treating physicians or to the women themselves anything about the nature of what had happened to them. A woman diagnosed with psychotic reaction in 1952 was a woman who carried that diagnosis and its implications through her subsequent life without the benefit of a more specific understanding of what had actually occurred and what it actually meant for her future. The argument for including a specific postpartum category in the diagnostic manual was made periodically throughout the latter half of the 20th century, and it was an argument that raised genuine scientific questions about whether postpartum psychiatric disorders were truly distinct conditions with their own biology and course and prognosis, or whether they were simply standard psychiatric conditions with a postpartum precipitant, not different in any clinically relevant way from the same conditions arising in other contexts. This argument continues to generate productive scientific debate, and its continuation reflects genuine uncertainty about the biological mechanisms of postpartum mood disorders that has not yet been fully resolved. But in 1952, the argument was moot because it was not being made in any form that influenced the treatment of the women who needed it. The woman in the state hospital ward had been admitted under a diagnosis that told her treating physicians she was psychotic and required institutional management and physical treatments. The diagnosis was wrong or imprecise in ways that had direct consequences for the treatment she received and the understanding, or the absence of understanding, that she came away with. She did not know the diagnosis was imprecise. She did not know it was wrong. She was in no position to challenge it, and the name she needed, the name that would have allowed her and her physician and her husband to understand what had happened to her as a medical event with a known course and a known treatment and a known prognosis, did not exist in the language available to any of them. Names matter. They matter in medicine in particular because medicine is organized around them. The diagnosis is the document that determines treatment and prognosis, and communication and understanding, and the absence of the right diagnosis is an absence that has consequences that extend far beyond the immediate clinical encounter. The woman who went home from the psychiatric institution without the name was a woman who spent the following years without the explanation that would have reorganized her understanding of what had happened. She understood what had happened to her through the available framework, which was the framework of personal failure and inadequate motherhood, and she carried that understanding because no one gave her a better one and none was available. The name would come. Postpartum depression as a specific and clinically recognized condition began to gain ground in the psychiatric and obstetric literature in the 1960s and 1970s, driven by the feminist health movement's insistence that women's health experiences deserved specific clinical attention, by the work of researchers who studied the hormonal and neurological changes of the postpartum period with increasing sophistication, and by the testimony of women who had experienced what they were now, for the first time, able to call by its name. The Edinburgh Postnatal Depression Scale, introduced in 1987, gave clinicians a validated screening tool that made the identification of postpartum depression in primary care settings possible in a way it had not been before. Postpartum Support International, founded in 1987, created a community and an advocacy infrastructure that transformed the experience of women who were suffering from what was now, finally, a named and publicly acknowledged condition. But that was 1987, it was 1952, and the name had not come. And the woman in the ward was sleeping or not sleeping, and the ward was quiet around her, and there was no name for what she had, and no treatment adequate to it, and no framework that would have allowed anyone in her life, including herself, to understand it as what it was. It is worth sitting for a while in the specificity of what her days were like, because the clinical record and the theoretical account can give the impression that what happened to these women was primarily a story about ideas and structures, when it was also, and perhaps more essentially, a story about specific hours in specific rooms with specific people, and about the small things that made those hours bearable or unbearable, and about the particular quality of time in an institution where you did not choose to be. The ward woke early, 6 o'clock or 6:30, the particular time established by the institution, and maintained with the institutional consistency that was itself one of the distinctive features of this life. The sound of the day beginning was the sound of institutional beginnings, the clatter of the breakfast cart in the corridor, the business of the morning nursing staff arriving, and the night staff handing over, The voices at the nurses' station with their particular professional tone. If you had slept, you had slept in the way that institutional sleep was possible, lightly, with the particular awareness of not being alone that made genuine rest difficult. The awareness of other bodies in the room, and the institutional sounds that continued through the night at the low volume that was still louder than the silence of a private bedroom. You rose when the routine said to rise, which was not when your body said to rise, because your body had stopped having reliable opinions about such things, and the routine had taken over the function of organizing your day into the required sequence of activities. You made your bed, or were assisted in making it, depending on the day and the state you were in, because the bed making was part of the daily routine that the institution maintained, for reasons that were partly therapeutic in the sense that occupational therapy understood therapeutic and partly simply institutional, the habit of order that large managed populations required. Breakfast was at 7. The dining room had long tables and the smell of institutional food, which was a specific smell composed of cooked starch and institutional cleaning products, and the background odour of many meals prepared in the same large kitchen and consumed in the same enclosed space over many years. The food was edible, and sometimes more than edible, depending on the institution and the cook and the day of the week, and mealtimes were among the moments of institutional life that most resembled ordinary life in that they involved sitting at a table with other people and eating and talking, if you were in a condition to talk. The women at the tables came from many different circumstances and carried many different histories, and the texture of the social world of the ward was created by the intersection of those histories in the confined space of the institutional day. There were women who had been in the hospital for weeks, and women who had been there for months, and women who, in the state hospitals, had been there for years, had been there so long that the institution had become their primary social world and their reference point for normalcy. The acute patients, the women who had arrived recently in the aftermath of a postpartum episode or some other acute psychiatric crisis, occupied one social register, defined by their recent arrival and the sense of shock that had not yet fully worn off. The chronic patients occupied another. The friendships that formed between patients were, for many women, among the most significant aspects of the institutional experience, and they deserve more acknowledgement than the clinical literature of the period gave them. The woman who found, across the dining room table or in the occupational therapy room or during the supervised hour in the garden, another woman whose history resonated with her own, who understood without explanation what it meant to be in this place and to have come here the way she had come, was a woman who had found something the institution did not officially provide and did not fully comprehend. Mutual recognition between people who shared a specific form of experience that no one outside could entirely understand. These friendships had their particular character. They were formed in the institutional context, which meant they were formed in the absence of the ordinary social infrastructure of shared community and shared history and the gradual mutual revelation that civilian friendships were built on. They were formed quickly, the way friendships form in any confined and intense situation, and they were sustained by proximity and by the shared predicament rather than by the ordinary social negotiations of adult life. They were also formed in a context of ongoing distress and uncertainty, which gave them a quality of intensity and mutual dependence that was different from the quality of ordinary adult friendship. Some of them lasted a lifetime. Women who were discharged from these institutions, who returned to their houses and their families and the ordinary world that had continued without them, sometimes maintained contact with women they had known in the ward, through letters and occasional visits and the particular ongoing relationship of people who carry a shared secret. The shared secret was not shameful, though the culture of the era often required them to treat it as such. The shared secret was, I was there, I know what it was like, you do not have to explain it to me. The visiting hours, typically Sunday afternoons and perhaps one evening per week, were the moments when the institutional life made contact with the life outside, and the contact was both a relief and a disruption. The husband arrived or did not arrive. He brought the child or did not bring the child, the decision about whether to bring the child being one of the most consequential decisions made about her care, and one that was rarely if ever made with her explicit input. The question of whether to bring the baby was a question the physicians and the husband negotiated between them, and the clinical rationale for not bringing the baby, that seeing the baby might destabilize her, that the visit might be too emotionally intense, that she was not ready, was a clinical rationale that was sometimes correct and that was also sometimes a way of managing the difficulty of the visit for the husband, who was not always ready for the emotional complexity that his wife holding their child in a hospital visiting room would produce. When the baby was brought, the visit was suffused with a quality that the visiting room could not adequately contain. The child who was brought to see its mother was a child who had been away from its mother for weeks or months, and the reunion that happened in the visiting room was a reunion that was not quite a reunion because it happened in the wrong place and under the wrong conditions and would end at the visiting hour's close. And the ending was a grief that she had to absorb in the presence of other patients and their families because the visiting room did not offer privacy. She held the baby while the baby was willing to be held, and looked at the face that had changed since she had last seen it in the ways that babies' faces change in the first weeks and months of life. The specific changes that she had not been present for, and she felt what she felt, which was a mixture of love and longing and guilt and something that was almost joy but could not quite become joy in this place. When the baby was not brought, the visit was a different kind of difficulty. The husband sat across the table, and they talked about the things that were available to talk about in the visiting room, under the implicit supervision of the staff, and she did not ask about the baby in a way that might be recorded as problematic, as evidence of anxiety or instability, and he did not say the things about the baby that might have helped her, most to hear, because he was not sure which things those were, and the visiting room was not a place that made it easy to find out. They said goodbye at the visiting hour's close, and she watched him go, and the afternoon had a specific quality of emptiness that would last until the morning brought the routine back. The physicians made their rounds, typically once or twice per week for individual patients, more often for those in acute phases. The clinical interview was the central clinical event of the week, the moment at which her condition was formally assessed and her treatment adjusted, and the notes made in her file that would constitute the medical record of her stay. The clinical interview was conducted by the physician, in a room that was more private than the ward but still carried the institutional quality of the institution, and the conversation that happened in it was a conversation shaped by the power differential between the physician who was assessing her and the patient who was being assessed. She knew in these interviews that what she said mattered in ways that ordinary conversation did not. She knew that her responses were being interpreted, that the quality of her affect and the coherence of her thinking and the appropriateness of her emotional responses were being noted, and that what was noted would influence the decisions about her care. She had no way to know in most cases whether her sense of her own improvement corresponded to the physician's clinical assessment of it, because the clinical assessment was not typically communicated to her in the transparent way that would have been most useful. She was told what she needed to know, which in the framework of 1950s psychiatry was less than what she needed and sometimes less than she was ready for. The nights in the institution were the institution at its most itself. The day with its routines and its activities and its social structure had ended, and what remained was the ward at night, the rows of beds in the dim light, the occasional sound from another patient, the night shift aide in the corridor, and her own thoughts in the particular darkness of an institutional room. The nights were when the weight of everything she could not control was most fully present. The distance from her baby, the uncertainty about when she would be discharged, the memory gaps that the treatments had left, the deep uncertainty about who she would be when she was finally allowed to leave. She lay in the dark and she breathed and she tried to find in the breath something that was hers, something the institution had not organized or administered or decided for her, something that remained genuinely her own. The breath was hers. The thinking was hers, though the treatments had made it intermittently unreliable. The love she carried for the baby was hers, the most unambiguously hers thing in this place, where so much else had been determined by others. She held on to it in the dark. She held on to it and waited for the morning. The baby she left at 6 weeks old was a person, small and entirely dependent and neurologically in the most sensitive period of its early development, and the separation that her hospitalization imposed on their relationship was not a neutral event in the baby's life any more than it was a neutral event in hers. The developmental psychology of attachment had not been fully articulated in 1952. John Bowlby's attachment theory, which would transform the understanding of the infant-caregiver relationship and the consequences of its disruption, was in the process of being developed in the early 1950s and would not reach its full formulation until the publication of his 3-volume work on attachment and loss between 1969 and 1980. The research of Harry Harlow on rhesus monkeys, which provided experimental evidence for the primacy of the attachment relationship in early development, was being conducted in the 1950s and early 1960s. The broader scientific and clinical understanding of what early separation from the primary caregiver meant for an infant's development, for its emotional regulation, its capacity for relationship, its sense of safety in the world, was not available to the physicians who were managing the cases of hospitalized mothers or to the husbands who were making decisions about whether and how often to bring the baby to visit. What was known in 1952 was that babies needed to be fed and kept warm and protected from physical harm, and that when a mother was unable to provide these things because she was in a psychiatric institution, someone else had to provide them, and the hospital was not that someone. The baby stayed home. The baby was cared for by whoever could be arranged, a grandmother who came and stayed, an aunt, a neighbour who could be paid for a few hours a day, a hired woman whose qualifications were primarily her availability and her willingness to take the job. The quality of this care was enormously variable and was determined by the resources and the networks of the family in question, rather than by any systematic assessment of what the baby needed. The 6-week-old baby who lost its primary caregiver was a baby who lost, with that caregiver, the specific sensory world of that relationship, the particular smell and voice and touch and way of being held that the baby had been learning to recognize and to expect since before it was born. This is not a sentimental point. The neuroscience of early attachment has established, since Bowlby's foundational work and the decades of research it generated, that the consistent sensory presence of the primary caregiver is not a luxury in the first months of life, but a developmental necessity, that the regulatory co-regulation that happens between an attuned caregiver and an infant is the mechanism by which the infant's nervous system learns to regulate itself, and that disruption of this relationship in the earliest months has consequences for neurological and emotional development that persist into later childhood and, in significant forms, into adult life. None of this was known in 1952 in a form that would have changed clinical practice. The baby left at home was regarded as adequately cared for as long as its physical needs were met, and the question of what the baby needed from its specific mother, as distinct from a competent female caregiver in general, was not a question that the clinical framework of 1952 psychiatry was equipped to ask. The longer the hospitalization, the longer the disruption. A woman who was hospitalized for 2 weeks and returned to her baby at 8 weeks postpartum was returning before the most sensitive period of early attachment formation was fully passed, and the disruption she was managing was different from the disruption managed by a woman who was hospitalized for 6 months and returned to a baby who was now 7 months old, who had learned a different caregiver's face and voice and smell and ways, and for whom the woman now presenting as mother was a stranger in the most fundamental neurological sense. The return home was not a restoration of what had existed before the hospitalization. It was the beginning of a new process of relationship formation between a mother and a child who had developed without her during the period of her absence, a process that required patience and attunement and time, and that was taking place in a domestic situation that had its own demands, that did not pause for the process of repair. The woman who came home was already managing the residual effects of her illness, which had not necessarily fully resolved, and the physical and cognitive after-effects of the treatments she had received, and the institutional experience itself with its institutional damage, and the disruption to her marriage and her domestic authority and her social relationships, and now also this, the rebuilding of the relationship with her child. Some of these rebuilding processes went well. Some mothers and children found their way back to each other with a naturalness that appeared to contradict the prediction that the separation had permanently disrupted the relationship. The human capacity for relationship formation is resilient in ways that the worst scenarios do not always materialize, and there were women who came home and held their babies and felt the recognition and the love that had been inaccessible during the illness arrive with a completeness that was itself a form of healing, a recovery not only of the woman but of the relationship between mother and child. But there were also children who carried the consequences of the separation in ways that did not resolve with the mother's return. Children who had formed their primary attachment to a substitute caregiver and who responded to their returned mother's attempts at relationship with the ambivalence or the avoidance that disrupted attachment patterns produce. Children who had learned, during the months of maternal absence, that the reliable presence of a caregiver was not something they could take for granted, and who carried that learning into a hypervigilance or a clinginess, or a withdrawal that made the mother's task of rebuilding the relationship more difficult, and that she was, in many cases, not equipped to understand as what it was. The longer-term consequences of early maternal hospitalization for children's development have been studied retrospectively in the work of researchers who have traced the developmental trajectories of children who experience maternal psychiatric hospitalization in infancy. The findings are complex and do not support simple narratives of inevitable damage or inevitable resilience, but they do consistently identify elevated rates of emotional and behavioral difficulties in children who experience significant early separation from their mothers, particularly in the context of mothers who themselves were dealing with ongoing psychiatric difficulties and limited social support after discharge. The children who grew up and did not know what had happened were a specific category of consequence. The woman who came home and resumed her domestic role without ever discussing with her child what had occurred during those absent months was following the social script of her era, which was a script that did not acknowledge mental illness as something that could be discussed with children without causing harm. The child who grew up knowing that something had happened in its first year of life but not knowing what, or knowing in the children's versions that were available, which were not accurate versions, was a child who had a gap in its own history that had not been explained and that generated the particular kinds of confusion and fantasy that unexplained gaps in family history always generate. Some of these children, grown to adulthood, went looking for the records. They found what was findable in hospital records and family documents and the accounts of relatives who remembered what had been kept from them, and what they found reorganized their understanding of their own early lives in ways that were sometimes liberating and sometimes devastating. The knowledge that their mother had been ill, had been hospitalized, had not chosen to leave, that the absence they had in some unconscious way registered and incorporated into their understanding of themselves and the world was not abandonment but illness, was a knowledge that arrived decades after it would have been most useful, and that carried its own particular freight of grief for the time that had passed without it. The children who were never told, whose parents took the secret with them, are also part of this story, though they are harder to locate in it because the record of their not knowing is the absence of a record. They are present in the gaps, in the family histories where the early months are not discussed, in the particular emotional configuration of people who have learned, without being taught explicitly, that some things are not spoken of in this family, and that the reasons for this are not available and should not be pressed. The baby in the crib was not old enough to understand any of this. The baby was 6 weeks old, and then 7 weeks old, and then 3 months old, and then 6 months old, in the ordinary miraculous progression of infant development, and it was being cared for and fed and held, imperfectly but adequately in the physical sense, and it was growing. And somewhere, at a distance that might have been measured in miles, or might as well have been measured in the distance between an institutional ward and the domestic life it had interrupted, its mother was also growing, in the painful institutional sense, toward whatever version of herself she would be when she was finally released. They would find their way back to each other, or they would not, or they would find their way to something new that was not quite the same as what they would have had if none of this had happened, and it would be enough, or it would not be quite enough, or it would be more than enough in ways that no one had predicted when the car had pulled up to the institution on that first afternoon, and she had gone inside. The baby did not know any of this. The baby was learning the world from whoever was present, which is what babies do, with the absolute commitment of someone for whom the present is the only tense available. And somewhere, not far enough away, its mother was learning the institution, which was all that was available to her, in the same way. The day of discharge was prepared for with the particular anticipation that is only possible in a context where a specific day has been the object of sustained hope for weeks or months. She knew the date, or she learned it. There was a conversation with the physician in which the discharge was confirmed, a review of her condition that satisfied the institutional criteria for release, a conversation with her husband about the arrangements. And then there was the day itself, the morning of the day, which arrived with the ordinary quality of any morning in the institution, and which she moved through with a heightened attention to its ordinariness, because it was the last ordinary institutional morning, and everything after it was going to be different. The discharge itself was brief. There were papers, the administrative procedures of institutional release, the returning of any items that the institution had been holding, the final conversation with the ward staff. Some of the women with whom she had shared the ward said goodbye, or would say goodbye at the next meal, or had been discharged before her and were already gone. The goodbye to the institution that had been her world for however many weeks or months had a complicated quality that she had not expected. It was relief, and it was apprehension, and it was something else, something harder to name, that had to do with leaving the people who had shared this experience and entering a world that had no way to understand it. Her husband was there to drive her home, or her mother, or some combination of the family that had organised itself around her absence. The drive home passed through the ordinary streets of the ordinary world that had been continuing without her, and the ordinariness of the world, the gas stations and the grocery stores and the children on bicycles and the housewives with their shopping bags, was itself a kind of shock after the institutional sameness of the ward, a world that had too much variety and too much colour and too much noise for the particular mode of perception she'd been living in. The house was the same house and was not the same house. The yellow curtains were still there, the refrigerator was still there, the kitchen had the smell of someone else's cooking habits, because whoever had been managing it in her absence had their own way of doing things, and the smell of that was a detail that carried more information than she had expected, about how completely the household had organised itself without her. She stood in the kitchen that was hers, and was also not quite hers anymore, and tried to find the right way to be in it. The baby. The baby was the thing the return was for, the point around which everything else organised, and the reunion with the baby was the event she had been imagining and rehearsing and holding on to through the institutional weeks. The baby was here, was in someone's arms or in a crib or being held out toward her, and she reached for the baby with the movement of a person who has been waiting for this specific moment for a long time, and the baby responded in the way that babies respond to things, which is variously and not always according to expectation, and what happened in the first few minutes of their reunion was the beginning of a process that neither of them understood, and both of them would be living for the months and years that followed. What was not provided at discharge was as significant as what was. In most cases in the 1950s there was no discharge plan in the sense that the term is now understood. No structured follow-up with a community mental health professional, no referral to an outpatient therapist who would continue the work begun in the institution, no scheduled appointment with the family physician to monitor her progress in the first weeks at home. There was the discharge itself, and then there was the assumption that she was well and would manage, an assumption based on the clinical judgment that she met the criteria for discharge, which were the criteria of institutional psychiatry, and which did not include any assessment of the adequacy of the domestic situation to which she was returning. She was returning to the situation that had, at least in part, precipitated the crisis. She was returning to the domestic isolation of the suburban house, to the sole care of a baby who was now 3 or 6 or 12 months older than when she had left, to the marriage that had survived her absence in whatever form that survival had taken, to the neighbourhood where her absence had been explained or not explained, and where she was now subject to the particular social scrutiny that returning from a psychiatric hospital carried in 1950s America. She was returning to all of this with no professional support, with the residual effects of her illness that had been treated but not cured, with the memory disruption that the treatments had left, with the disruption to her sense of herself as a competent person and a competent mother that the institutionalization had produced, and with no way to tell anyone how she was actually doing without risking the judgment that she was not well enough and needed to go back. This last constraint was perhaps the most crippling. The social stigma attached to mental illness in the 1950s was total and unqualified, and the specific stigma attached to a woman who had been in a psychiatric institution was a stigma that affected her relationship with her neighbours, her family members who had not been told or had been told partial truths, the other mothers in the neighbourhood with their babies and their apparent competence, and above all her relationship with the medical system that had the authority to readmit her if it deemed her insufficiently recovered. The prudent course was to appear well, to perform recovery, to maintain the presentation of functional domesticity that was expected of her, and to manage whatever she was still experiencing privately and silently. The silence was the same silence she had maintained before the hospitalization. She had not told anyone the truth before, because there was no language for the truth, and the culture had no tolerance for it, and she was not telling anyone the truth now because the stakes were, if anything, higher. She had now demonstrated, by virtue of having been hospitalized, that she was capable of breaking down, and the tolerance for any further indication of instability was lower than it had been before. The neighbour who had gone through a difficult postpartum period herself but had managed without hospitalisation might be sympathetic, might be genuinely understanding, might be a source of support. Or she might be someone who looked at the returned woman from the institution with the specific combination of sympathy and wariness that mental illness produced in people who had not experienced it. Her husband was navigating the return too, in his own way. He had managed the household and the child for however many months, and he had a husband's version of whatever had happened during those months, a version in which he had held things together and made the necessary arrangements and waited for her to get well, and the version he brought to her return was not always the same version she had been waiting for. There were marriages that survived the hospitalisation and the return, and became eventually something stronger for having been through it together, couples who found that the crisis had forced a kind of honesty and depth into their relationship that it had not had before. There were also marriages that did not survive, or that survived in name only, diminished by the isolation and the fear and the accumulated distance of the months of separation and the managed performances of the reunion. The children who had been born before this one, if there were older children, had to be managed in the context of the return. They had their own experience of their mother's absence, their own version of the story that had been told to them, their own relationship with the period in which she had not been there, and the resumed daily life of the family included the complexity of restoring the threads of those relationships, alongside the primary task of re-establishing the relationship with the new baby. The woman who came home without a discharge plan, without professional follow-up, without any structured support for the transition back to domestic life, was managing all of this on the same resources, or diminished versions of them, that had been inadequate before the hospitalisation. The difference, if there was one, was that the most acute phase of the illness had been addressed, that the worst of the symptoms had been reduced to a level that the institution considered consistent with release, and that she was now, according to the clinical record, a recovered patient. Whether she was actually recovered, in the sense of having access to the resources and the understanding and the support that would allow her to manage the demands of her domestic life without returning to the crisis point, was a question that the discharge process was not designed to ask. Some women went back. Some were readmitted within months of their first discharge, and the readmission carried its own additional burden of shame and failure on top of the first one, because the first hospitalisation had been understood as the crisis, and the return home had been understood as the recovery, and the second hospitalisation meant that the recovery had not been complete, which was interpreted as a personal failure rather than as a predictable consequence of returning to an unchanged situation without adequate support. The women who did not go back managed in the ways available to them. Through the slow passage of time, which was a genuine therapeutic agent even in the absence of any other, through the bonds with their children that were rebuilt week by week through the ordinary daily work of caring, through the marriages that held, through the friendships that survived, through the private resources of resilience and persistence, and the kind of determined forward motion that women of that generation had been trained to maintain regardless of what lay beneath it. They managed, many of them, well enough. They lived their lives. They raised their children. They were present in their communities in the ways that were expected of them. What they did not have, most of them, was any adequate understanding of what had happened to them. The name was not there. The explanation was not there. The context that would have allowed them to understand the hospitalisation not as evidence of their inadequacy, but as a medical event that had happened in a specific historical and cultural moment, a moment shaped by assumptions that were wrong, and by a medical system that was doing its inadequate best within those assumptions, was not yet available. They carried what they carried, which was considerable, and they carried it in the way that women of their generation carried things, quietly, with the appearance of competence and the maintenance of the required domestic performance, and with the private weight of something they could not put down and could not fully name and could not explain to anyone who had not been there, and which they did not try to explain because the trying had not, in their experience, led anywhere useful. The women who were in psychiatric institutions in the early 1950s and who also wrote are an overrepresentation of a category, which is to say that writers, by virtue of being writers, produce the documentary record that most other categories of people do not. The women who were in those institutions and who did not write left a different kind of record, or left no record at all, and the history we have of this period is partly a history of writers and partly a history of the institutional records that survived and are accessible, and it is not the full history of what the institutions contained. But the writers matter, and their writing matters, not only because it is beautiful, and because it provides a perspective on the institutional experience that no clinical record can match, but because it reveals, with the specific clarity that literature provides, the intersection of personal psychological suffering and social constraint that produced the particular crisis of the institutionalized woman in 1950s America. Sylvia Plath was admitted to McLean Hospital in Massachusetts in 1953 at the age of 20 following a suicide attempt. She was not a postpartum patient, though she would later give birth to 2 children, and her experiences in the institution preceded the period we are primarily discussing by a few years. But her account of the institutional experience in the Bell Jar, published in 1963, provides the most widely read literary record of what psychiatric institutions were and what they did to the women they contained, and it cannot be omitted from any account of this period. What Plath documents in the Bell Jar is not only the experience of mental illness itself, though she documents that with an accuracy and a clarity that readers who have experienced what she describes recognize with the particular shock of recognition that great literature about suffering produces. She documents the relationship between her illness and the cultural context that shaped it, the specific nexus of the 1950s pressure on women to conform to a domestic ideal, and the psychic cost of that pressure in a woman with a different kind of mind and a different kind of ambition. She documents the institution and its treatments, the electroconvulsive therapy that is the most frequently quoted passage in the novel, with an unblinking attention to what the experience was actually like from the inside. And she documents the return, the attempt to re-enter the world that had both produced the crisis and continued to insist on its own adequacy while she was in the institution recovering from it. Anne Sexton provides a different literary window onto the same period. Sexton began writing poetry after being hospitalized following a suicide attempt in 1956, at the age of 27, and her subsequent psychiatric treatment under the care of a therapist who encouraged her to write poetry as a therapeutic practice produced some of the most significant confessional poetry in American literature. Her poems about motherhood, about mental illness, about the institutional experience, about the specific texture of being a woman in mid-century America who was also someone who was breaking down within the constraints that same mid-century America had built, are documents of an experience that the clinical literature could not provide. Sexton was a wife and mother, and her breakdown was explicitly entangled with the demands of the domestic role that the culture had assigned to her. Her relationship to her children during the periods of her psychiatric treatment, the absences and the returns and the ambivalences and the love that coexisted with the ambivalence, is recorded in her poems in ways that have given subsequent readers, including women who experienced similar situations decades later, a language for experiences that they could not otherwise have named. Her poetry is not a case study. It is something more useful. It is the inside of the experience, expressed in the only form adequate to convey what it was like to be her in those years. The existence of Plath and Sexton in the literary record of this period should not obscure the reality that their accounts represent a small and specific segment of the women who were in psychiatric institutions in the 1950s. They were educated women of relative privilege at institutions that had better resources and more individualized care than the state hospitals that housed most patients. They were white. They were writers, which meant they had access to a mode of self-expression and self-understanding that was not available to most of the women who shared their institutional experience. They survived long enough to produce the literary record, though Plath died by suicide in 1963 and Sexton in 1974, deaths that are part of the record too. The women who were not writers, who left no literary record, whose experience is recoverable only through the institutional documents that chronicled their care and the family memories that were transmitted through the decades, were the majority. Their experience was not less real and not less significant for the absence of a literary record. The woman who left no poems and no novels, but who sat in the same dining room and received the same treatments and lay in the same ward at night and missed her baby with the same specific wordless intensity as the woman who wrote poems about it, is as central to this history as the women whose experience became literature. The autobiographical memoir became, in the decades after the 1950s, another mode through which women's experiences of psychiatric institutionalization were documented and made available to a wider readership. Works published beginning in the 1960s and continuing through subsequent decades gave readers accounts of institutionalization that were written from the inside, by women who had been in these institutions and who had survived them, and who wanted the record to reflect what they knew. These accounts varied in tone and in the nature of their critique. Some were primarily personal testimonies, focused on the individual experience. Some were more explicitly political, connecting the individual experience to the structural conditions that had made it possible. Some were accounts of eventual recovery and the transformation of the institutional experience into something survivable and even, in certain formulations, useful. The feminist health movement of the late 1960s and 1970s drew on these literary and autobiographical sources to construct a political analysis of what had been done to women in psychiatric institutions, an analysis that connected the specific experience of hospitalization to the broader structure of male authority over female bodies and female minds that had characterized both medicine and law through the preceding centuries. This political analysis was itself a form of naming, a naming not only of the individual experience, but of the structural conditions that had made it possible, and it created the intellectual and political context in which the subsequent advocacy for women's mental health would take place. Our bodies, ourselves, the Women's Health Manual, first published by the Boston Women's Health Book Collective in 1970, represented a particular kind of intervention. It put medical information directly in the hands of women, bypassing the physician-mediated model of health information that had been the only available model throughout the period we're discussing. It included information about mental health and psychiatric treatment that enabled women to understand what was being done to them and to ask questions and, in appropriate circumstances, to refuse. This was not a small thing. The authority to refuse treatment, to insist on information, to participate in the decisions about one's own care that the legal reforms of subsequent decades would formally recognize, was asserted by the feminist health movement before the law caught up to it. The literary and political record of women's experience of psychiatric institutionalization is, taken together, one of the most significant documents of the second half of the 20th century, and its significance lies not only in what it reveals about the past but in what it produced for the present. The vocabulary, the analysis, the political framework, and the community of women who recognized each other's experience across the page that made possible the advocacy and the reform that came. The woman at the kitchen table in 1952 did not have any of this. She did not have the words, and she did not have the analysis, and she did not have the community, and she did not have the political framework. She had the cold coffee and the terror that had no name and the baby in the next room and the doctor who was coming. But the women who came after her, who experienced their own versions of her situation in subsequent decades, came into a world that was, slowly and incompletely, being changed by the words that women like Plath and Sexton, and the authors of subsequent memoirs and the founders of the feminist health movement had produced. The words made the change possible. This is the work that literature does, and it is not a small work. For every woman who was hospitalized following a postpartum episode in the 1950s, there were many more who were not. The women who were not hospitalized were not in most cases women who did not suffer. They were women who suffered in the domestic space, without institutional management, without clinical intervention, without the formal recognition of their condition as something that warranted medical attention, and who managed the suffering in the only ways available to them, through the private resources of individual resilience, through the informal support networks of family and neighborhood, through the passage of time, through the eventual, usually partial and rarely named, resolution of the acute phase of what they were experiencing. The decision about whether a woman who was struggling in the weeks and months after childbirth in the 1950s received professional attention was determined by a combination of factors that had little to do with the severity of her suffering and much to do with the visibility of her suffering, the temperament and the attentiveness of her husband, the proximity and involvement of her extended family, the sensitivity of her family physician, and the degree to which her suffering broke through the surface of the domestic performance she was maintaining. A woman who was deeply depressed but functional, who got up every day and fed the baby and kept the house and had dinner on the table at 6, was a woman who might not come to the attention of the medical system at all. The depression was present. It was there in the quality of her attention and in the specific texture of her days and in the relationship she had with her baby, which was not the relationship she had been promised, which was adequate but not warm, caring, but not connected in the way she'd been told connection would feel. But it was invisible in the clinical sense, invisible to the husband who came home at 6 and saw the dinner on the table and the baby fed and the house maintained, who understood his wife to be managing perfectly well. The women in this category, the vast majority of women who experienced postpartum depression in the 1950s, are largely invisible in the historical record because their suffering did not produce a clinical event. They did not appear in hospital records or institutional files or the documentation of treatment. They appear occasionally in the retrospective accounts they gave to researchers and journalists in subsequent decades, when the name for their experience had arrived, and they recognized it and found, sometimes with the shock of belated naming, that what they had experienced decades earlier in the kitchen of a house in the suburbs was the thing that was now being talked about on television and written about in books. These retrospective accounts are their own form of testimony, and they have their own particular character. The woman who is 65 years old in 1985 and who reads an article about postpartum depression for the first time and recognizes in it the experience she had in 1952, 33 years ago in the kitchen with the cold coffee and the 6-week-old baby, and the terror that had no name, is having a form of recognition that reorganizes her relationship to her own history. She's finding out 3 decades too late that what she had was a condition with a name and a biology and a treatment, that she was not uniquely and personally failing at the most important thing she was ever asked to do, that other women had sat at tables like hers with coffee cups like hers and had felt the same impossible distance between themselves and the life they were supposed to be grateful for. What she does with this recognition depends on who she is and what she still has available to do with it. Some women were able to integrate the late naming into a revision of their understanding of those years that allowed them to put down some of the self-reproach they had been carrying. Some were not able to fully revise the earlier understanding, which had had 30 years to calcify into the way they understood themselves and their history. Some were angry, with the specific anger of someone who understands that they were wronged by the unavailability of knowledge that existed, and was simply not organized in a way that was accessible to them when they needed it. Some were primarily relieved, even decades later, to have the name. The informal support networks that helped women manage postpartum depression at home in the 1950s were the networks that the suburban house had disrupted in its physical isolation and that women rebuilt through the social structures available to them, the phone calls to mothers and sisters and friends, the neighborhood coffee clatches where women sat in each other's kitchens and talked about things in the carefully edited way that women talked about things when the full truth was inadvisable, the church communities that provided both practical assistance and a social context in which distress could be expressed in the language of spiritual struggle rather than psychiatric pathology. These networks were uneven in their availability and in their adequacy. The woman who lived near her mother and who had a sister she could call, and who had a neighbour who had been through it, and who went to a church with a women's group that met weekly, was in a significantly different situation from the woman who had moved to a suburb 300 miles from her family of origin, and who knew no one in the neighbourhood well enough to be honest, and who went to a church that was formal and community in only the most superficial sense. The geography of social support in the 1950s was a geography shaped by the post-war dispersal of extended families, and the women who landed far from their networks of origin were the women most exposed to the particular isolation of the suburban house, with its appliances and its loneliness. Some women turned to religious frameworks for the management of their distress. The spiritual language of suffering and endurance and God's purposes was available to women of faith as a way of understanding what they were experiencing that the medical language of their era could not provide, and it served, for some women, the function of giving the suffering meaning and context, even as it sometimes obscured the medical nature of what was happening. The woman who understood her postpartum depression as a spiritual trial to be endured rather than a medical condition to be treated was not always worse off for this understanding. The resources of faith, the prayer and the community and the sense of larger purpose could be genuinely sustaining, but the framework could also prevent her from seeking appropriate medical attention, could contribute to the interpretation of her suffering as something she was supposed to manage herself through spiritual resources rather than something she was entitled to present to a physician as a medical complaint. The children of the women who managed at home carry a different kind of record than the children of the women who were hospitalized. They were present, their mothers were present, the daily texture of early childhood was not disrupted by a sudden maternal absence. but the presence of a depressed mother is its own developmental experience, different from hospitalization, but not necessarily without consequences. The research on children raised by mothers who were experiencing untreated postpartum depression in the first year of life has found elevated rates of emotional and behavioral difficulties in middle childhood, difficulties in attachment security, difficulties in self-regulation, that parallel in some respects the difficulties found in children who experience maternal separation, though through a different mechanism. The child whose depressed mother was present but not fully available, whose mother could go through the motions of care without the attuned responsiveness that the care was supposed to carry, was a child in a relationship that was organised around the mother's difficulty in a way that the child could not understand and had no choice but to adapt to. The adaptations were the child's only available response to the emotional reality they were living in, and those adaptations shaped their expectations about relationships and their strategies for managing emotional experience in ways that persisted beyond the resolution of the acute phase of the mother's illness. The women who managed at home without professional help are not all the same. Some of them recovered more completely than the women who were institutionalized, because their recovery happened in the context of their ordinary life and their relationships, without the additional disruption of institutional management, and without the self-alienating experience of being removed from the domestic role that was, however ambivalently, the center of their social identity. Some of them recovered less completely because the absence of any clinical intervention meant that the acute phase persisted longer and caused more damage to the relationships and the self-concept that the women needed for their longer-term welfare. The outcome was not determined by the presence or absence of hospitalization, but by the complex interaction of the severity of the illness, the quality of the informal support available, the individual's own psychological resources, and the specific circumstances of the domestic situation to which they were confined. What they shared, the hospitalized women and the women who managed at home, was the absence of the name. None of them had the name in 1952, and the absence of the name was a form of suffering that was added on top of the suffering of the illness itself, the specifically human suffering of having something happen to you that you cannot explain and that your culture has organized to understand as your fault. The name would come. It was coming slowly through the work of researchers and advocates and the women who insisted on telling their stories, and it would arrive in time to help some of them, and not in time to help others, and the record of its coming is the record of the second half of the 20th century's slowly improving relationship with the truth of what women's postpartum experience was, and what it needed and why what was being provided was inadequate. In the kitchen, the coffee had gone cold again. The baby was asleep. The woman at the table was still at the table, and the day was very quiet. History does not change by itself. History changes because people decide that what is happening is not what should be happening, and then work to make the difference between those two things visible, and then, having made it visible, work to close it. The history of the reform of psychiatric treatment for postpartum women in America is a history of people who made that decision, and of the coalitions they formed, and of the specific changes those coalitions achieved, and of the changes they did not achieve, which remain as the ongoing work of the present. The reform did not begin in a single place or with a single person. It began in the convergence of several developments that were not originally connected, but that came together over the course of 2 decades to produce the conditions for change. The feminist health movement contributed the political analysis that connected women's psychiatric treatment to the broader structure of male authority over female bodies and minds, and the demand that this authority be democratized and that women's health experiences be understood as women themselves understood them rather than as the physicians who treated them defined them. This was a radical shift in the underlying epistemology of medicine, and it met with the resistance that radical epistemological shifts typically meet. But it was also a shift that produced concrete changes: the right to informed consent, the right to refuse treatment, the right to seek a second opinion, the right to access one's own medical records, all of which were fought for and won in the course of the 1970s and 1980s. The legal reform of psychiatric commitment law was a parallel development that began in the 1960s and accelerated through the 1970s. The Supreme Court's 1975 decision in O'Connor v. Donaldson established that a state cannot constitutionally confine a non-dangerous person who is capable of surviving safely in freedom, a decision that established for the first time a constitutional limit on involuntary psychiatric commitment, and that effectively ended the era in which a husband could commit his wife on a physician's certificate without any judicial review. The legal reforms that followed in state after state during the 1970s required that involuntary commitment be preceded by a judicial hearing, that the persons subject to commitment have the right to legal representation, and that the clinical grounds for commitment be demonstrated to a legal rather than merely a medical standard. These legal reforms were imperfect and incomplete. They did not end involuntary psychiatric treatment. They did not eliminate the power differentials that had shaped the 1950s commitment system. They did not ensure that women with postpartum psychiatric disorders received appropriate, adequate voluntary care in their communities so that involuntary commitment would not become the only available intervention. But they fundamentally changed the structure of authority within which psychiatric treatment operated, and they established the principle that the person subject to commitment had rights that the commitment process was required to respect, which was a principle that the 1950s system had not acknowledged. The clinical advances were more gradual and more uneven. The development of effective antidepressant medications, beginning with the tricyclic antidepressants in the late 1950s and continuing with the selective serotonin reuptake inhibitors beginning in the 1980s, transformed the available pharmacological treatment for depression in ways that allowed for effective management outside the institutional setting in most cases. The woman with postpartum depression in 1987 had access to medications that could reduce the severity of her symptoms without the institutional management that had been necessary in 1952, when the only pharmacological options were sedatives and the early antipsychotics. This was a genuine advance, though the question of how to manage antidepressant use during breastfeeding and the specific hormonal biology of the postpartum period continued to present clinical challenges that required ongoing research and ongoing adjustment of clinical guidelines. The Edinburgh Postnatal Depression Scale, developed by John Cox, Jennifer Holden and Ruth Sogowski, and published in 1987, was a specific and practically significant contribution to the clinical identification of postpartum depression. It was a validated screening tool that could be administered in the primary care setting by a midwife or a general practitioner, and that produced a score that indicated the likelihood of postpartum depression with sufficient sensitivity and specificity to identify women who needed further assessment and support. Before the Edinburgh Scale, the identification of postpartum depression in primary care settings was dependent on the physician's individual clinical awareness and the woman's willingness to disclose her symptoms, both of which were highly variable and often insufficient. After the Edinburgh Scale, the identification could be systematic and standardized, and could happen at the routine postpartum visit rather than only in crisis situations. The implementation of universal screening using the Edinburgh Scale was not immediate or complete, and it continues to vary by geography and by the specifics of healthcare system design. But the existence of the tool created the possibility of systematic screening in a way that had not previously existed, and the gradual adoption of that screening transformed the identification of postpartum depression from an event that happened when a woman's suffering became visible enough to produce a clinical crisis to something that could happen in the ordinary course of postpartum care. Postpartum Support International, founded in 1987 by Jane Honickman following her own experience of postpartum mood disorder, created the first national organisation explicitly dedicated to the support of women and families affected by postpartum psychiatric disorders. The organisation's combination of advocacy, education, community support and professional training represented a model of patient-centred mental health advocacy that had not previously existed for this population, and its influence on the clinical awareness of postpartum mood disorders among healthcare providers and on the cultural awareness of those conditions among the general public has been significant. The FDA approval in 2019 of brexanolone, marketed as Zulresso as the first medication specifically approved for the treatment of postpartum depression, represented a milestone in the formal recognition of postpartum depression as a biologically specific condition requiring targeted pharmacological intervention. Brexanolone is a synthetic form of allopregnanolone, a neurosteroid that fluctuates dramatically during the peripartum period, and its therapeutic mechanism reflects the growing understanding of the hormonal biology of postpartum mood disorders. Its approval was the product of decades of research into the specific neurobiology of the postpartum period, and represented, in formal regulatory terms, the acknowledgement that postpartum depression was not simply ordinary depression, with a postpartum precipitant, but a condition with its own biological specificity that warranted its own targeted treatment. The approval of brexanolone came 67 years after the woman at the kitchen table sat with her cold coffee and her terror and her 6-week-old baby and no name for what was happening to her. 67 years. It is worth pausing at that number. It is worth letting the specific weight of that interval sit without rushing past it. 67 years in which women experienced what she experienced and were treated with what was available and often received care that was inadequate or harmful or both. While the research proceeded at the pace that research proceeds, and the advocacy accumulated and the political conditions for change developed, and the science matured. The rate of change was the rate it was. The advocates worked as hard as they could within the systems they were working in, and the researchers worked as hard as they could within the funding structures and the scientific paradigms available to them, and the women who testified about their experiences testified as publicly and as clearly as they could within the social and cultural constraints they were operating in. The rate of change was still 67 years. The woman at the kitchen table deserved better. Every woman who sat at a table like that one, before the name came and before the treatment arrived and before the legal protections were in place, deserved better than what the world of their moment was able to provide. That acknowledgement does not change what happened to them. It does not provide the name they needed when they needed it. It does not give back the months in the institution, or the early months with the baby that were lost. It is simply the truth, stated without mitigation, and it is the truth that the history requires. We are not in 1952 anymore. It is worth stating that plainly and without irony, because the distance travelled between then and now is real, and represents genuine human effort and advocacy, and scientific progress and the stubbornness of people who refused to accept that what was happening was adequate. A woman who gives birth today in the United States and who begins to experience the symptoms of postpartum depression is in a situation that is, in most of the ways that matter most, better than the situation of the woman at the kitchen table in 1952. She's in a situation where the condition she's experiencing has a name that is widely known and publicly acknowledged. She lives in a culture that has, at least partially, accepted that postpartum depression is a medical condition rather than a personal failure, that the gap between the cultural mythology of maternal bliss and the actual experience of new mothers is real and significant, and not the mother's fault. She has access, in most healthcare settings in most parts of the country, to a screening tool that can identify her condition before it reaches a crisis point. She has access, through Postpartum Support International and the many organisations and online communities that have been built in the decades since its founding, to communities of other women who have experienced what she is experiencing and who can provide the recognition and the support and the practical guidance that the institutional system of 1952 could not offer. She has access, through her physician or her midwife, to pharmacological treatments that are more effective and better tolerated than the treatments available in 1952. And she has the legal right to refuse any treatment she does not want, to insist on a second opinion, to participate in the decisions about her own care. These are real advances, they should be named as what they are, which is the product of decades of advocacy and research and the stubbornness of women who refused to be silent about what they were experiencing and who refused to let the medical system define their experience in terms that served the system rather than the patients it was supposed to serve. But the situation today is not adequate, and pretending it is would be a disrespect to the ongoing suffering of women who are experiencing postpartum depression right now, in the present tense, without adequate access to the care they need. Screening rates for postpartum depression remain inconsistent across the healthcare system. The existence of the Edinburgh Postnatal Depression Scale does not guarantee that it is being administered, and the rates of screening vary enormously by geography, by healthcare setting, by the specific practices of individual providers, and by the insurance status and socioeconomic circumstances of the patients being served. Women who are poor, who are without insurance, who live in rural areas with limited access to primary care, who are members of communities of colour in which the legacy of medical mistrust is justified by a specific history of medical racism, are disproportionately likely to be underscreened and undertreated for postpartum depression, a pattern that echoes, in a different register, the unequal distribution of suffering that has characterised the history we have been tracing. The cultural stigma attached to mental illness, while reduced from its 1950s form, has not been eliminated, and the specific stigma attached to a new mother who is not experiencing the joy that she is supposed to be experiencing remains a barrier to disclosure that many women navigate in the clinical encounter. The physician who asks how she's doing at the 6-week postpartum visit, and who receives the answer that she's doing fine and who does not press further, is receiving an answer that may be the full truth, or may be the performance of a truth that is too frightening to admit. The question of how to create clinical encounters in which women feel safe enough to be honest about what they are actually experiencing is not a question that has been fully answered by the existence of a screening tool. The treatment access gap remains. Even women who are correctly identified as experiencing postpartum depression, who receive a clinical diagnosis and a treatment recommendation, face barriers to accessing that treatment that reflect the broader failures of the American healthcare system. The wait for a psychiatric appointment can be weeks or months. The cost of therapy for the women who do not have adequate mental health coverage can be prohibitive. The practical challenge of finding childcare in order to attend therapy appointments is real and not always solvable. The woman who has been told she needs therapy and who cannot access therapy for practical and financial reasons is in a better situation than the woman who was not told anything in 1952, but she is not in an adequate situation. The specific inadequacies of postpartum mental health care for Black women, Latina women, Indigenous women, and immigrant women reflect both the general failures of the healthcare system with respect to these populations and the specific ways in which postpartum mental health research and treatment have been developed primarily with white women in mind, producing clinical tools and treatment approaches whose applicability to women of different cultural backgrounds has not always been adequately evaluated. The work of ensuring that postpartum mental health care is equitable and culturally competent is work that is ongoing and insufficiently resourced. The father's role, and the partner's role more broadly, in both postpartum well-being and postpartum care has received increasing attention in recent decades. The recognition that partners can also experience postpartum depression, that the mental health of both parents affects the well-being of the baby and the family unit, and that adequate postpartum care should address the entire family system rather than only the mother, represents a genuine conceptual advance over the 1950s model in which the father was the authority over the mother's care rather than a potential recipient of care himself. The implementation of this understanding in clinical practice is, like so much else, uneven and incomplete. And there is the question, which has no simple answer, of whether the fundamental cultural conditions that generated the crisis of the 1950s have been adequately transformed. The mythology of maternal perfection, the expectation that new mothers will feel the right things in the right ways from the moment of birth, and will manage the demands of early parenthood with competence and grace and the appearance of ease, has been modified but has not been dismantled. The social media environment of the present adds its own specific form of pressure, a visual culture of maternal perfection that is curated and presented in the intimate space of the mobile phone, and that reaches new mothers in the middle of their most difficult nights. The isolation of the nuclear family, the lack of structural support for new parents, the expectation that child rearing will be managed within the household without significant community infrastructure has persisted in different forms from the 1950s suburbs to the present. The woman who's awake at 3 a.m. with a baby who will not sleep, scrolling through a feed of smiling mothers with perfectly lit photographs of peaceful infants, is experiencing something that rhymes with the experience of the woman at the kitchen table in 1952, even though the technologies are different and the name is now available, and the cultural acknowledgement of postpartum depression is now at least partial. She is experiencing the gap between what she was promised and what she is living. She is experiencing the particular loneliness of a difficulty that is common, but that feels individual, a difficulty that she suspects other women are not having, a difficulty that she interprets, despite everything that has changed, as evidence that something is wrong with her, rather than as evidence that something is wrong with the structures that have failed to support her. The work is not finished. The naming was the beginning, not the end. The legal reforms were the beginning of a project of equal rights for psychiatric patients that is still in progress. The development of effective treatments was the beginning of a pharmacological and therapeutic project that continues to require research and funding and clinical attention. The advocacy work of Postpartum Support International and similar organizations is ongoing and requires the ongoing support of everyone who understands what is at stake. The women who are experiencing postpartum depression right now, tonight, in the silence of houses where the babies have finally stopped crying and the rest of the household is asleep, deserve the same quality of care and the same cultural support and the same absence of stigma that the reform advocates have been working towards since the 1960s. They deserve not to have to sit at the table alone with the cold coffee and the terror that cannot be named. They deserve, at minimum, the name. The woman at the kitchen table in 1952 had a life that continued beyond the moment we have been following. She came home from the institution, or she did not come home and was transferred to a long-term facility, or she came home and returned again, or she came home and stayed and managed imperfectly and with the resources available to her, the life she'd been handed. The historical record we have of individual women from this period is fragmentary. The hospital records that survive tell clinical stories, admission date, diagnosis, treatments administered, notes on clinical progress, discharge summary. They are documents produced by institutions about patients, and they carry the specific limitations of that genre, which is that the person being documented is visible in them only as a collection of symptoms and responses to treatment, and the physician's judgment about the adequacy of those responses. The person's own understanding of what was happening to her, her own experience of the illness and the treatment and the institutional life, is absent from these records in the way that the patient's perspective is systematically absent from clinical documentation of this era. The oral histories that have been collected by researchers and journalists and documentary makers beginning in the latter decades of the 20th century provide a different kind of record. They are the records of women who were willing to talk about what had happened to them, who had survived long enough to be available for the telling, and who had access to the retrospective understanding that the naming of their condition had eventually provided. These oral histories are partial and selective in their own ways, shaped by the decades that had passed between the event and the telling, by the specific framings that the women had found for their experience, by the things that could be said and the things that still could not be said even after decades, but they are the closest we have to the inside of the experience. What these oral histories reveal, taken together, is the range of what the experience produced over the course of a life. There are women who describe the hospitalization as, in retrospect, a turning point that was eventually helpful, even though it was experienced as devastating. Women who found in the institutional period, in the forced removal from the overwhelming demands of domestic life, a rest that they had been unable to take voluntarily, and who came out of it with some capacity for recovery that the continued domestic situation might not have provided. These accounts are not endorsements of the system that hospitalized them. The system was wrong in too many ways to be endorsed. But they are honest about the complexity of what the experience produced, which is a complexity that the simple narrative of harm without benefit would not fully capture. There are women who describe the hospitalization as an experience from which they never fully recovered. Not because the illness itself was irremediable, but because the institutional experience added specific, lasting damage to the illness's already significant toll, the memory disruption from the treatments, the disruption to the relationship with the baby that the absence had caused, the damage to the marriage that the hospitalization and its aftermath had accelerated, the self-concept of the woman who had been defined by her institutionalization in ways that her community would not let her revise. For these women, the hospitalization was not a parenthesis in a life that resumed approximately as before. It was a pivot that changed the direction and the quality of everything that followed. And there are women who describe something more complex and less easily categorized, a life in which the hospitalization was one event among many, difficult and significant but not necessarily defining, absorbed into a life that continued to include love and work and relationships and the specific satisfactions and the specific griefs that any life includes. These are perhaps the most honest accounts, because they resist the narrative simplification that both the triumphant recovery story and the narrative of permanent damage can impose on experiences that are more variable and more conditional than either narrative allows. The children of these women have their own accounts, which are the accounts of people who knew their mother after the hospitalization, who may or may not have known about the hospitalization, who carry in their bodies and their emotional lives some record of what their earliest months were like, a record that the body keeps even when the conscious mind has no access to it, a record that expressed itself in the specific ways they formed attachments and regulated emotions and understood the reliability of the adults who were supposed to take care of them. Some of these children grew up to write about their mothers. Some grew up to become researchers who studied the conditions their mothers had suffered from. Some grew up to become advocates for better postpartum mental health care, the specific anger of a person who understands, from the most personal possible perspective, what the inadequacy of care costs. Some grew up never knowing what had happened and carrying the effects without the story, the specific mystery of a gap in their own early history that no one had explained. The granddaughters of the women of the 1950s are giving birth now in the 21st century. They are giving birth with the name available to them, and the screening tools and the medications and the Postpartum Support International hotline, and the online communities of women who understand and the legal protections and all the imperfect and incomplete but real advances that the intervening decades have produced. They are also giving birth into a healthcare system that remains inadequate in specific ways, a culture that retains the mythology of maternal perfection in new technological forms, an economy that makes the practical management of new parenthood more difficult than it should be. The grandmother who sat at the kitchen table in 1952 did not know that her suffering would become, in some partial and indirect way, the engine of change that would make her granddaughter's situation better. She was not suffering for her granddaughter. She was simply suffering, in the way that people suffer when they are ill, and have no name for the illness and no adequate treatment and no adequate support, which is to say, completely and without consolation. The fact that the suffering contributed to a history of advocacy and reform that eventually improved the situation for subsequent generations is a meaning that could only be imposed on it retrospectively, by people looking back with the advantage of knowing how the story continued. But looking back is what history does, and the retrospective meaning is not nothing. The women of the 1950s, the ones in the institutions and the ones at the kitchen tables, and the ones who managed somehow, and the ones who did not manage, and the ones who wrote, and the ones who were never able to write, are part of the history that produced the present, the specific present in which the name exists, and the treatment exists, and the advocacy exists, and the community exists. Their suffering was not wasted, though it was not necessary either. Nothing about it was necessary or inevitable. It was the product of specific historical conditions, specific political choices, specific professional failures, and cultural assumptions and legal structures that could have been different, and eventually were made different, and that remain imperfectly different in the ways that this account has tried to trace. The woman at the kitchen table deserved a world that could see her suffering for what it was and could respond to it with the recognition and the care and the adequate treatment that it required. She did not have that world. She had the world of 1952, and she made of it what she could, and what she could make of it was a life, which was not nothing, which was, in fact, everything. We sit with her for a moment now, in the quiet of the early morning, in the kitchen with the pale light coming through the yellow curtains, in the last moment before the doctor comes and the next part of her story begins. We sit with her, and we see her, which is something she needed and did not have, and which costs nothing to provide except the willingness to look without turning away. She's 26 years old. She's sitting at the table. The coffee has gone cold in her hands. The baby is quiet in the next room for now, in the temporary peace of early morning. She is not failing. She is ill. She deserves better than what is coming. We know this now. This is what we know. For the women who were not discharged within weeks but who remained in psychiatric institutions for months or years, the institutional experience had dimensions that the shorter hospitalizations did not produce, dimensions that accumulated over time like geological strata, each layer shaped by the one beneath it. The woman who had been in the institution for 6 months was a different person in relationship to the institution than the woman who'd been there for 6 weeks. Not different in her underlying identity, which persisted with the stubbornness that identity persists even in the most thorough institutional environments, but different in the specific way she had learned to inhabit and navigate the institutional world. She knew the rhythms now in the way that you learn the rhythms of any place you live in long enough. The good days and the bad days of the staff, the patients who could be trusted and the ones whose distress was volatile in ways that required careful management. The small variations in the daily routine that carried information about the institutional mood, the specific strategies that made the passing of time more bearable, and the specific errors that made it less so. Long-term institutionalization in the 1950s was not unusual. the state hospital population of more than 500,000 patients in 1955 included a significant proportion of patients who had been resident for years, and in some cases decades, patients for whom the hospital had become the primary social world, and whose connection to the civilian life outside it had attenuated to the point where the prospect of discharge was no longer the organising hope of their daily existence. The acute patients, the women admitted following postpartum crises who had a life to return to, and whose illness was, in clinical terms, episodic rather than chronic, were in a different category from these long-term residents. But they shared the same institutional space, and the presence of the long-term patients was itself an education in what the institution could do to a person over time if the person stayed long enough. The woman who had been in the institution for a year had had time to observe this process. She had watched patients arrive and patients leave and patients arrive again. She had watched some patients improve in ways that the institution recognised and that led to discharge, and she had watched some patients worsen in ways the institution attributed to the progress of their underlying illness, but that she sometimes suspected reflected the institutional environment itself. The specific damage that could be done by long enough removal from the ordinary demands and relationships of civilian life, by the progressive atrophying of the social skills and the domestic competencies, and the sense of oneself as someone capable of managing in the world. The institutionalization syndrome was described by the sociologist Irving Goffman in his 1961 book Asylums, which provided the most influential sociological analysis of the total institution and its effects on the self of the people it contained. Goffman described a process he called mortification of the self, by which the institutional practices of stripping the patient of the markers of her individual identity, her clothing and her personal possessions and her name and her role and her ordinary social relationships, produced a systematic dismantling of the self that preceded any therapeutic rebuilding. His analysis was produced by observation in an era slightly after the period we're discussing, but the conditions he described were the conditions of the institutions that housed the women of the 1950s, and his account of what those conditions did to the selves they contained was an account that many of those women would have recognized immediately. The specific quality of long-term institutionalization for women who had been mothers before their admission was shaped by the ongoing reality of the child growing up outside the institution, growing through the developmental stages that the mother was not present for, a growth that she tracked through the photographs and the letters and the reports of visitors, through the specific knowledge that she had missed the first word and the first step and the first day of school, and the birthdays and the ordinary daily events that constitute a childhood seen from the inside. The child was aging toward her. Every month of her institutionalization was a month of the child's development that she had not witnessed and could not recover. The women who were institutionalized for years and who eventually returned to families in which the children were now school-aged or older came home to relationships that had developed around their absence in ways that required extensive and patient rebuilding. The child who had been 3 months old when its mother was admitted and who was now 5 years old did not have a conscious memory of its mother's presence in its earliest months. The mother it knew was the mother who came to visit, or was the mother it did not know because the visits had been infrequent or had stopped. The mother who came home after years was a stranger in the emotional, if not the legal sense, and the work of becoming known to her own child was work that had to be done in the context of a domestic life, that also required managing in a marriage that had survived, or not survived, and a physical and cognitive condition that may not have been fully restored by the institutional treatments. The institutions were aware in varying degrees that long-term hospitalization produced its own specific pathologies. Some institutions in the 1950s had begun to experiment with open ward policies and therapeutic community approaches that attempted to moderate the worst effects of total institutionalization, allowing patients more freedom of movement, more participation in decisions about their daily lives, more engagement with the civilian world through supervised community activities. These experiments were significant and represented a genuine clinical insight about the secondary damage that institutionalization itself was causing. But they were unevenly implemented. They were often reversed when institutional pressures of overcrowding or understaffing made them impractical, and they did not reach the majority of state hospital patients in the early 1950s. The deinstitutionalization movement that began in the late 1950s and accelerated dramatically through the 1960s and 1970s, driven by the combined forces of the new antipsychotic medications that made community management more feasible, the fiscal pressures on state governments that were funding the enormous expense of the state hospital system, and the civil libertarian critique of involuntary institutionalization that the legal reform movement was making, reduced the state hospital population from its 1955 peak of 559,000 patients to fewer than 100,000 by 1988. This was, in many respects, a genuine liberation for many patients who had been confined in institutions that were causing them harm through the institutionalization process itself, but it was also, for many patients, a transfer from institutional care that was inadequate to community care that was even more inadequate, because the community mental health infrastructure that was supposed to support the discharged patients had not been built at the scale required. The women who were discharged in the wave of deinstitutionalization were discharged into a community system that was supposed to provide ongoing care, but that frequently did not, and some of them ended up cycling through emergency psychiatric services and temporary housing and the other inadequate substitutes for the community care that they needed and that had not been provided. This is a different story from the story of the women of 1952, but it is a related one. It is the story of what happens when an inadequate institutional system is reformed without the community infrastructure that would make the reform genuinely beneficial. The women of the 1950s who were over-institutionalized, who were kept in hospitals they did not need to be in, or for longer than they needed to be there, were harmed by the inadequacy of the system that held them. The women of the 1970s and 1980s who were discharged before adequate community support existed were harmed by a different inadequacy of the same system. The pattern is the same, the needs of the patients being secondary to the requirements of the system, whether that system is organized around institutional management or institutional cost-cutting. The women who navigated these systems, who survived the institutions and survived the return, and survived the inadequate community support, and who lived their lives, are the centre of this history, not the institutions and not the legal reforms and not the pharmacological advances, important as all of these are. The institutions are structures, the reforms are events, the women are people, and the people are what the history is for. In the institutional ward, in the long years of the 1950s when the state hospital population was at its peak and the reforms had not yet come, there was a specific quality to the time that passed. It was time that was organised by others, moved at the pace that others determined, filled with the activities that others had decided were appropriate. It was time that was not hers in the ordinary sense, not time she had chosen or shaped or directed, but time that passed nonetheless, one institutional day after another, until enough days had passed that the clinical staff decided she was ready to return to the life that had been waiting for her on the other side of the institutional walls. And she returned. Or she did not return. Or she returned, and the returning was the beginning of another kind of story, the long story of how you put a life back together after it has been disassembled by illness and by the system that was supposed to help you with the illness, a story that does not end with the discharge from the institution, but that continues, in one form or another, for as long as the person is alive to live it. The physicians of 1952 who were treating women with postpartum psychiatric presentations were not working in a scientific vacuum. They had the access to a body of medical knowledge accumulated over the preceding decades that informed their clinical decisions. The problem was not that they had no knowledge. The problem was that the knowledge they had was, in the areas most relevant to their patient's actual condition, significantly incomplete, organised by theoretical frameworks that were wrong in important ways, and supplemented by cultural assumptions that were so thoroughly embedded in the frameworks of medical practice that they were invisible as assumptions rather than as facts. The hormonal biology of the postpartum period was poorly understood in 1952. The role of the reproductive hormones, specifically estrogen and progesterone, in mediating mood and psychological well-being had been noted in the clinical literature but had not been studied with the methodological rigour that would allow for genuine scientific claims about mechanism. The dramatic hormonal changes of the peripartum period, the progesterone and estrogen levels of pregnancy that dwarf the normal hormonal range of the non-pregnant woman and that drop precipitously in the hours and days following delivery, were documented in the endocrinological literature of the period. But the connection between these changes and the psychological symptoms of postpartum mood disorders had not been established in a way that had penetrated clinical practice. The neuroendocrinology of the postpartum period, including the role of oxytocin in mother-infant bonding, and the specific ways in which the hormonal shifts of the peripartum period interact with the neurotransmitter systems that regulate mood and anxiety would not be investigated with the tools necessary for genuine mechanistic understanding until the 1970s and beyond, as neurochemistry and neuroendocrinology developed the methodological capabilities required. The woman who was experiencing the precipitous hormonal withdrawal of the immediate postpartum period in 1952 was experiencing a neurobiological event whose mechanisms were not understood by anyone, and whose treatment could therefore not be targeted to those mechanisms. The neurosteroid hypothesis of postpartum depression, which has become central to contemporary understanding of the condition and which underlies the mechanism of brexanolone as a specific pharmacological treatment, proposes that the dramatic changes in allopregnanolone, a neurosteroid derived from progesterone during the peripartum period, are a key contributor to the development of postpartum mood disorders in susceptible women. Allopregnanolone is a positive allosteric modulator of the GABA-A receptor, the same receptor system targeted by benzodiazepines and barbiturates, and the withdrawal from the elevated allopregnanolone levels of late pregnancy to the low levels of the immediate postpartum period produces in some women a syndrome that resembles the neurological withdrawal from GABA-active substances. This is a model that was entirely unavailable in 1952. The GABA receptor had not yet been characterized. The neurosteroids had not yet been identified. The concept of allopregnanolone as a neurologically active compound did not yet exist. The physicians of 1952 were treating a neurobiological event whose mechanisms were invisible to the scientific tools of their era, and their treatment reflected the limits of what those tools could reveal. The genetic component of postpartum depression, which subsequent research has indicated exists, and which contributes to the risk that women with a personal or family history of mood disorders will experience postpartum episodes, was similarly unknown in 1952. The field of psychiatric genetics was in its early infancy, and the specific genetics of mood disorders, which would require decades of twin studies and family studies and eventually genome-wide association studies to begin to characterize, had not been investigated in any form relevant to clinical practice. The physician who was treating a woman with postpartum depression in 1952 had no information about her genetic risk profile that would have allowed him to identify her as someone who was particularly vulnerable to this kind of episode or to monitor her with particular attention in the peripartum period. The psychological research on the specific stresses of the early postpartum period, including the sleep deprivation, the social isolation, the dramatic role transition, the loss of the occupational and social identities that had organized the prematernal self, and the specific demands of infant care on the attentional and emotional resources of the new mother, had not been conducted in 1952. The study of these stressors as contributors to postpartum mood disorders required a willingness to take women's subjective experience seriously as data and to investigate the social conditions of early motherhood as relevant to clinical outcomes, a willingness that the dominant research paradigms of 1952 psychiatry did not fully possess. What was known, and what was acted on with a confidence that exceeded its justification, was the clinical observation that severe postpartum presentations looked like psychosis, that the symptoms were dramatic, and the functional impairment was severe, and the condition could progress to dangerous behavior if not managed, and that the institutional and physical interventions that psychiatry had developed for psychosis were the appropriate responses. This was not unreasonable as a first approximation given the diagnostic tools available. It was inadequate as a complete account of what these women were experiencing and what they needed. And the treatment that followed from it, the institutional management and the physical treatments, caused harms that were not offset by equivalent benefits in a significant proportion of the women who received them. The research that produced the current understanding of postpartum depression was produced over the course of the second half of the 20th century by researchers who were willing to ask questions that the frameworks of 1952 were not asking, questions about hormonal mechanisms, about genetic risk, about psychological and social contributors, about the specific biology of the peripartum period and its relationship to mood regulation. This research was produced by people who treated the subjective experience of their patients as legitimate data, who listened to what women said about what they were experiencing and built their hypotheses around those reports rather than dismissing them as symptoms of pathology. The translation of this research into clinical practice into the screening tools and the evidence-based treatments, and the clinical guidelines that now organize the standard of care for postpartum mood disorders, represents the practical achievement that the research made possible. It is not complete. The evidence base for specific treatments, particularly for postpartum psychosis, remains thinner than it should be. The research on postpartum mood disorders in women of colour, in women from diverse cultural backgrounds, in women with other complicating clinical and social circumstances, is less comprehensive than the research in the populations that were studied most extensively. The translation of research evidence into clinical practice in community settings, particularly in under-resourced settings serving high-risk populations, remains partial. But the scientific foundation that now exists for understanding and treating postpartum mood disorders is genuinely different from what existed in 1952, and the difference is not trivial. It is the difference between treating a condition whose mechanisms are unknown, and whose treatment is therefore necessarily empirical and imprecise, and treating a condition whose mechanisms are at least partially understood, and whose treatment can therefore be targeted in ways that increase the probability of benefit and reduce the probability of harm. The physician of 1952 was doing his best with the tools he had. His tools were inadequate. The physician of today has better tools, though not yet adequate ones. The physician of the future will have better tools still. Each generation of physicians inherits the tools that the preceding generation's research has produced, and the quality of those tools is a function of the quality and the volume and the direction of the research that produced them, which is a function of the political will to fund that research and the scientific commitment to ask the right questions. The women of the future will be treated with the tools that the decisions made today about research funding and research direction will produce. This is the ongoing obligation that the history we have been tracing makes visible. In every account of the psychiatric institutions of the 1950s, the physicians appear as the authorities and the patients as the subjects of authority, and this structure was real, and its description is accurate. But between the physicians and the patients, occupying the daily texture of the institutional life in ways that the physicians did not and could not, were the nurses and the psychiatric aides and the occupational therapists and the social workers, the people who were in the ward every day, who managed the daily rhythm of institutional life, who had the most sustained and most intimate contact with the patients in their care. These people deserve more attention than the history of this period typically gives them, both because their presence shaped the quality of the patient's experience in ways that the physician's twice-weekly clinical interview could not match, and because they occupied a position that was genuinely complicated by the institutional hierarchy within which they worked, a position that required them to implement decisions they had not made and to manage the consequences of policies they had not designed, while also, in many cases, holding their own clinical knowledge and their own ethical commitments about what their patients needed. The psychiatric nurses of the 1950s were trained in a profession that had a complicated relationship to its own professional identity. Nursing more broadly was in the process of developing its professional autonomy and its own evidence-based practice in this period, asserting its clinical knowledge and its right to clinical judgment against the physician-directed model that had organized medicine for the preceding century. Psychiatric nursing specifically was developing a distinct specialty identity that would eventually produce its own theoretical frameworks and its own clinical approaches. But in the early 1950s, the psychiatric nurse was primarily understood as an extension of the physician's clinical authority, responsible for implementing the treatment plan that the physician had determined rather than for exercising independent clinical judgment. Within these constraints, individual nurses found ways to practice with genuine care and clinical intelligence. The nurse who knew her patients well enough to notice a change in mood before it was reflected in the clinical interview, who brought that observation to the physician's attention, and whose observation influenced the clinical decision-making, was exercising a form of clinical intelligence that the formal hierarchy did not recognize but that the patient's welfare required. The nurse who sat with a patient in the difficult evening hours, who listened to what the patient said and responded with the kind of human presence that the institutional structure was not designed to provide, was doing something that was not on her official job description, but that was among the most therapeutically valuable things that happened in the ward. The occupational therapist occupied a somewhat different position, one that was structured differently by their professional training and its philosophical orientation. Occupational therapy had developed from the tradition of moral treatment, and its practitioners were trained in a philosophy of care that emphasized the patient's own capacities and goals and the therapeutic value of meaningful activity and engagement. This philosophy was, in certain respects, more genuinely patient-centered than the physician-directed model of psychiatric treatment, and the occupational therapists of the 1950s often had a clearer understanding of their patients as people with individual identities and specific capacities than did the physicians who directed the overall treatment plan. The occupational therapy sessions in which women made ceramics or painted, or did the various craft activities that the institutional setting provided, were not trivial. They provided, within their scope, a space in which the patient was recognized as someone with skills and preferences and aesthetic sensibilities, not only as someone with symptoms and a diagnosis. The occupational therapist, who noticed that a particular patient was gifted with colour or with form, who found a way to make the activity sessions meaningful to that specific person, was practicing a form of individualized care that the institutional system was not, in most cases, providing elsewhere. And the women who found in these sessions something that felt genuinely like themselves, a continuity with the person they had been before the illness and hoped to be after it, were finding in the occupational therapy room something that the ward could not otherwise give them. The psychiatric aides who managed the overnight shifts and the weekend coverage, and the periods when the professional staff were not present, were often the least trained and the least supported workers in the institutional hierarchy, and sometimes the ones with the most direct and most unsupervised contact with the patients. The quality of aid care was enormously variable, ranging from the genuine compassion of people who had chosen the work because they cared about the patients to the indifference or the occasional cruelty of people who had taken the work because it was available and who were not equipped for its demands. The patient who had a kind aide on the overnight shift, who knew that the aide would check on her in the hard 3 o'clock hour when the night was longest, who had established a small but real human connection with someone who was present when the rest of the staff had gone, had something that the clinical record did not document and that the official treatment plan had not designed, and that was nevertheless real in its effect on her ability to get through the night. The patient who had an indifferent aide, or an aide who managed distress with the minimal intervention approach that institutional exhaustion and inadequate training can produce, had a different experience of the same hours, an experience that reinforced the isolation and the sense of being managed rather than cared for. The social workers, where they existed in the institutional structure, occupied a bridging role between the institution and the patient's family and community, a role that had its own specific complexity. The social worker who made the assessment visit before the patient's discharge, who spoke to the husband and assessed the home situation, who was supposed to determine whether the patient was returning to a situation that would support her recovery, was exercising a clinical judgment that affected the patient's fate without, in most cases, substantive input from the patient herself about what she understood her home situation to be and what she needed for her return to go well. The social worker who was skilled and empathic and who understood the specific dynamics of the domestic situation to which the patient was returning, who could identify the risks and the resources and who could connect the patient with the limited community supports that existed, was providing a service that could genuinely improve the patient's post-discharge trajectory. The social worker who was overworked and whose caseload did not permit adequate engagement with each patient's specific situation, who made a perfunctory assessment and signed off on the discharge because the institutional pressures required the bed to be freed up, was providing a service that was inadequate to what the situation required. These were people doing their jobs in an institutional context that was under-resourced and overextended and organized by frameworks that limited what they could offer regardless of their individual commitment and skill. The good ones found, within those constraints, genuine ways to help. They are part of this history, and their contribution deserves acknowledgement even as the institutional structure within which they worked deserves the critique that this account has provided. The patient who was helped by a kind nurse or a skilled occupational therapist or a genuinely attentive aide was helped in ways that the official treatment plan did not recognize and that the clinical record did not document, and the help was real. The institutional record says, patient received electroconvulsive therapy on 12 occasions and was discharged in improved condition. The human record says, the occupational therapist let her choose her own projects and told her, in the matter-of-fact way of someone who meant it, that she had a genuine eye for colour. The nurse sat with her on the night of the hardest of the nights and held her hand and said nothing, which was exactly the right thing to say. The aide brought her an extra blanket when the ward was cold and did not make her ask for it. These were not the treatments, They were something else, something that does not have a clinical name and that cannot be systematized or standardized, but that the women who received them remembered sometimes more vividly than the treatments themselves, because they were the moments in the institutional experience when the human being in the ward was treated as a human being rather than as a patient. And that is a thing that is always felt, regardless of the circumstances. There is a particular form of historical reckoning that this story demands, and it is not the form that comes most easily. It is not the form in which the past is judged and found wanting, and then placed at a safe distance, arranged into a narrative that says, this is what they did then, and they were wrong, and we know better now, and the knowing better is the end of the story. That form is tempting because it is comfortable. It keeps the past on the other side of a boundary called then, where it can be examined and evaluated without the uncomfortable recognition that the conditions it describes have not entirely disappeared, that the mechanisms it traces are not entirely dismantled, and that the specific combination of cultural mythology and medical inadequacy and legal structure that sent women to psychiatric institutions in 1952 without their consent continues to have echoes and analogues in the present that are worth examining. The cultural mythology of maternal perfection has not been dismantled. It has been modified, transformed into new media forms, complicated by the partial acknowledgement of postpartum depression that the advocacy movement achieved. But the expectation that motherhood will be the fulfillment of a woman's deepest nature, that the love for a new baby will be immediate and complete and transformative in the ways that mothers are supposed to be transformed, that the mother who does not feel these things is deficient in some fundamental way, persists in the cultural landscape in forms that any new mother can identify. The social media feed full of radiant mothers and perfect infants is a technological descendant of the Ladies' Home Journal of 1952, performing the same function of prescribing to women what their experience of motherhood is supposed to be, and thereby adding an additional burden to the experience of women whose motherhood does not correspond to the prescription. The medical hierarchy that organized 1950s psychiatric treatment so that the physician's authority was total and the patient's authority was absent has been reformed but not dismantled. The informed consent requirements and the patient rights legislation of subsequent decades have established formal protections that did not exist in 1952, but the power differential between the physician, who has the knowledge, and the patient who needs it, remains, and the specific ways in which that differential operates to the disadvantage of women, of people of colour, of poor people, and of people whose distress is expressed in ways that the clinical framework is not designed to recognise are well documented in the contemporary medical literature. The legal structure that allowed a husband to commit his wife without her consent has been reformed. The commitment laws of every state now require some form of judicial review and provide patients with the right to legal representation and the right to refuse voluntary treatment. But the history of psychiatric commitment in the United States since the 1970s includes specific chapters that give reason for continued vigilance. The use of commitment to manage social problems rather than strictly clinical ones. The specific disproportionality of involuntary psychiatric treatment affecting black and brown communities. The ways in which the formal legal protections are undermined in practice by resource constraints and systemic bias, and the persistent belief, held by some clinicians and many members of the public, that people with serious mental illness cannot be trusted with authority over their own care. The isolation of the nuclear family structure, which placed the woman at the kitchen table in 1952 in a house with a baby and a husband who left at 7:30 and no adequate support network, has been modified but not fundamentally transformed. The suburban geography of the post-war period has been joined by the urban geography of expensive cities, in which young families are isolated in apartments, and by the rural geography of communities where services are scarce and distances are large, and the practical supports for new parents are minimal. The specific isolation of the first months of parenthood, in a country that provides no universal paid parental leave, no universal childcare, no community infrastructure for the support of new families, is a structural problem that the advocacy movement has named, but that the political system has not addressed. What this history demands of us, then, is not the comfortable form of reckoning in which we judge the past and feel vindicated in our present. It demands the more difficult form in which we use the past to ask questions about the present that we would not otherwise be motivated to ask. What are we assuming that we cannot see? What suffering is being organised by the available categories of our medical and cultural frameworks into a form that prevents its adequate recognition and treatment? Whose experience is being treated as a symptom of personal pathology, rather than as a reasonable response to structural conditions that deserve to be changed? Whose authority over their own care is being undermined by systems that believe they know better? These are not rhetorical questions. They are the questions that this history generates when it is read with the attention it deserves, and they are the questions that the ongoing work of postpartum mental health advocacy is organised around. The advocates of Postpartum Support International and the researchers in perinatal mental health, and the clinicians who have committed themselves to the care of women in the perinatal period, are doing work that is continuous with the work of every person who has ever pushed back against the framework that said women's postpartum suffering was their own fault. They are doing work that the woman at the kitchen table in 1952 needed and did not have, and that the women of the present need and deserve, and that the women of the future will need and will have in forms that we cannot yet imagine if the work continues. The work continues. This is not a small thing. In a history that contains a great deal of failure and inadequacy and harm, the fact that the work continues is the fact that points forward rather than back, the fact that is oriented toward the future rather than toward the past that produced it. The woman at the kitchen table deserved better. The women of today deserve better. The women of the future will have better if the work continues. It is enough for now to know that. It is enough to carry that knowledge into the night, into the ordinary darkness of houses where babies are sleeping and parents are awake, and the work of love continues without ceremony or acknowledgement in the small hours of the morning, as it has always continued, as it will always continue as long as there are people in the world doing the most difficult and the most necessary thing there is, staying present in the face of what is hard and refusing to turn away. The survivors of 1950s psychiatric institutionalization, who lived long enough to see the world change, who lived through the deinstitutionalization movement and the feminist health movement and the advocacy campaigns and the arrival of the name for what had happened to them, carry a particular form of knowledge that no amount of historical research can fully replicate. They know what the institution smelled like. They know the quality of the light in the ward at 3 a.m. They know the specific texture of the visiting room table under their hands when they were trying to maintain composure in front of a husband who could not quite look at them directly. They know what it felt like to be discharged, to walk out of the institution with whatever they had been given at intake, back into the world that had been waiting for them with its ordinary complexity and its inadequate understanding of where they had been. Many of them never spoke about it. The stigma was real, and the cost of disclosure was real, and the protection that silence provided was protection they had earned the hard way and were not willing to relinquish. They went home and resumed their domestic roles with whatever degree of authentic engagement they could manage, and they managed the private knowledge of what had happened with the privacy that the culture required, and they carried it for years and decades, and in some cases to the end of their lives, without it ever being acknowledged by the people around them as something that deserved acknowledgement. The specific quality of this silence deserves attention. It was not the silence of people who had nothing to say. It was the silence of people who had been taught that what they had to say was not welcome, that the saying of it would cost more than the keeping of it, that the world in which they lived had organised itself so that the story they carried was a story that could not be told without consequences that they were not in a position to bear. This is a specific kind of silencing, different from ignorance and different from indifference. A silencing that is produced by the accurate reading of a social environment that has made clear what it will and will not accommodate. The women who eventually did speak, who found in the changed environment of the 1970s and 1980s, and beyond a space in which the story could be told, and the telling would be met with something other than punishment, were often discovering in the process of speaking something about the story that the long years of silence had not allowed them to find. The act of narrating the experience, of putting it into the sequence of events that narrative requires, and thereby locating it in relation to everything else in their lives, was itself a form of processing that the original experience had not had access to. The therapeutic value of narrative was something that the psychotherapy of subsequent decades would investigate extensively, developing the theoretical frameworks and the clinical practices around trauma-informed care and narrative therapy, and the specific treatment of complex post-traumatic presentations that the women of the 1950s had not had available to them when they needed it. They were in some sense doing this work decades after the fact, discovering in the telling of their stories the processing that their stories had been waiting for. The grandchildren and great-grandchildren of these women are inheriting, sometimes without knowing it, the specific configuration of family that the institutional episode produced, the family in which a maternal absence in early infancy was managed in a particular way, in which the return of the mother was absorbed into the family's ongoing life with whatever degree of acknowledgement and integration was possible, in which the story of what had happened was told, or not told, and in what form and with what framing, is a family shaped by that history in ways that may not be visible to its current members, but that are present nonetheless in the emotional patterns and the relational templates and the specific configurations of attachment and autonomy and trust that families transmit across generations. The intergenerational transmission of trauma is a field of inquiry that has grown substantially in recent decades, developing both theoretical models and some preliminary empirical evidence for the mechanisms by which the experiences of one generation shape the psychological development and the relational patterns of subsequent generations. The specific transmission of the postpartum psychiatric crisis of the 1950s through family systems, through the specific ways that the crisis and its aftermath shaped the parenting of the women who experienced it, and thereby the attachment and the development of their children and grandchildren, has not been studied systematically, which means it is visible primarily through the clinical encounters and the therapeutic relationships and the family histories that clinicians and researchers and individuals come across in their practice. But the transmission is there. It is present in the way that history is always present in families, not as explicit memory but as pattern, not as story, but as the specific shape of the emotional life that the story produced. The great-granddaughter of a woman who sat at a kitchen table in 1952 and was never seen for what she was and what she needed is the great-granddaughter of a specific emotional inheritance, and whether that inheritance has been transmitted with the consciousness that would allow it to be examined and revised, or whether it has been transmitted silently in the way that most family inheritances are transmitted, is a question whose answer varies by family and cannot be generalized. What can be said is that the history does not end with the women who experienced it. It continues in their descendants and in the culture that their experience helped, slowly and inadequately but genuinely, to change. The change is partial. The inheritance is mixed. The work is ongoing. These things can all be true simultaneously, and the ability to hold them simultaneously without resolving them into a simpler story is the ability that this history requires. The woman at the kitchen table was not a symbol. She was a person, 26 years old, hands around a coffee cup that had gone cold, 6 weeks postpartum, terrified of something she could not name, alone in the kitchen in the early morning of a day in 1952 that she did not know was the last ordinary day for a long time. She was a person, and the people who came after her, in the institutions and in the kitchens and in the ward, in the late nights and in the visiting rooms and in the discharge process and in the return home and in the long years that followed, were all persons too, each of them complete and specific and deserving of a world that could see them and respond to them with the care that their specific situation required. The world has gotten better at this, not enough better, but genuinely better. The work continues. There is something that the photographs do not fully convey, and that the clinical records cannot convey at all, about the physical experience of a psychiatric institution in 1950s America. The photographs that exist from this period show the institutional buildings from the outside, the long low brick structures of the state hospitals, the more gracious neo-Georgian facades of some of the private sanitariums, the grounds and the gates and the official entrances, the exteriors that were designed to present a particular face to the world. What they do not show, because photographs were not typically taken there, is the inside of the wards, the day rooms and the dormitories and the corridors and the treatment rooms where the actual experience of institutionalization took place. The inside of a state psychiatric hospital in 1952 had a specific quality that former patients remember, with a consistency that suggests it was real and not merely individual. The smell first, disinfectant, that was not quite successful in covering the underlying smell of the building itself, which was the smell of many people in an enclosed space over many years, the specific institutional smell that is recognizable and unlike any other smell in civilian life. The sound, the particular acoustic of large institutional rooms, the The way voices echoed off the linoleum floors and the painted plaster walls, the background institutional sounds of a building that was always occupied, always in its particular kind of motion. The light, the fluorescent lighting that was standard in institutional settings of this era, a light that had the specific quality of institutional fluorescence, slightly greenish and slightly relentless, the light that was there in the morning and there in the afternoon and there in the evening, unchanging in its institutional consistency. The dormitory wards were the rooms where the patients slept, rows of beds in large rooms, each bed with its small adjacent cabinet that was the patient's only private space in the institution, the space in which she kept whatever personal possessions the institution allowed her to keep. The beds were institutional beds, the mattresses institutional mattresses, the pillows institutional pillows, and they were clean, and they were adequate in the physical sense, and they were nothing like the bed she had at home in the house with the yellow curtains, and the nothing-like quality was present every night when she got into the bed and lay in the dark of the dormitory ward and listened to the sounds of the other women breathing around her. The day rooms were the rooms where patients spent their unstructured time, sitting in the institutional chairs with the institutional magazines and whatever the institutional setting offered in the way of diversion. The day rooms of 1950s state hospitals were often large and sparsely furnished, with the combination of institutional durability and institutional aesthetic that characterized everything in these buildings. Furniture that would last and would not break, and would not be beautiful and would not be personal, and would not belong to anyone. The patients who sat in these rooms during the hours between scheduled activities were sitting in a space that had been designed for generic psychiatric patients rather than for specific people, and the generic quality of the space was itself part of the institutional message about who the patients were and what they were worth. The treatment rooms were the rooms where the specific medical interventions took place, and they had the specific quality of medical spaces. The table, the equipment, the clinical cleanliness, the smell of the institution's medical work. The electroconvulsive therapy suite, where it existed as a dedicated space rather than being conducted in a multipurpose room, had its particular atmosphere, which was the atmosphere of a room where something significant and potentially frightening happened, and the atmospheric quality persisted even when the room was empty. The private sanitariums were physically different in ways that were significant to the people who experienced them. The rooms were smaller and more private. The grounds were often carefully maintained, with the lawns and gardens that the institutional architecture of the 19th century had understood as therapeutically valuable, and that the private sanitarium had preserved in ways the state hospitals could not afford. The dining rooms of the private sanitariums had tablecloths sometimes, and the food was served rather than cafeteria style, and these details, which might seem trivial, were not trivial to the women who ate at those tables, because they were the details that said, "You're still a person to whom the ordinary niceties of human interaction are owed," rather than, "You're a patient who is being managed in a context where the management of large numbers requires the elimination of the ordinary niceties." But the physical difference between the state hospital and the private sanitarium, significant as it was in terms of daily comfort, did not change the fundamental structure of the patient's situation in either setting. The woman in the private sanitarium room was as unable to leave without authorization as the woman in the state hospital dormitory. Her treatments were determined by the clinical staff without her meaningful participation in either setting. Her discharge was controlled by the institution and her husband in either setting. The nicer room was a genuine good, and the tablecloth was a genuine good, and none of it was the fundamental good she needed, which was to not be there, to be home with her baby, to be recognized as someone who was suffering from something that had a name and a treatment that would allow her to function in her own life. The architecture of the institution communicated things that no one said explicitly. The locked doors communicated that she could not leave. The uniformity of the spaces communicated that she was one of many rather than one of one. The absence of anything personal in the common spaces communicated that the personal was not what the institution was organized around. The presence of the staff in their white uniforms communicated the hierarchy that organized the space and the people in it. She read these communications accurately because they were accurate, and she lived within what they communicated for whatever length of time the institution determined she needed to live within it. The institution at night had a quality that it did not have during the day. The day brought its rhythms and its activities and its social structure, and even in an institution these things provided a kind of scaffolding for the hours. The night stripped that scaffolding away. The night was the institution in its most institutional form. The dimmed lights and the muffled sounds and the dormitory ward with its rows of sleeping or wakeful or quietly distressed women, each in her own particular version of the institutional night, each with the particular content of her own particular suffering, each in the specific loneliness of a person who is surrounded by others and is nonetheless alone with what she carries. She lay in the dark and she breathed and she thought about her baby, because the baby was the North Star of her institutional existence, the fixed point to which all her internal navigation referred, the reason that whatever she was doing here was worth doing, the reason she was willing to let the institution do what it was doing to her, the reason she got up in the morning when the morning came. The baby was real. The baby was somewhere, in a specific house, in a specific crib, with a specific face that had changed since she had last seen it, and it was hers, and she was coming back to it, and whatever was happening here was temporary, or she told herself it was temporary, because the alternative was not something she was equipped to think about in the dark of the dormitory ward, in the institution, in the middle of the American century, in a year that would later be remembered for things that were not this. The lights in the corridor cast their particular institutional shadow under the dormitory door. Somewhere, in another room, a woman cried softly and then was quiet. The building breathed around her with its institutional breath. She was still here. She was going to be all right. She told herself she was going to be all right. The churches and the synagogues and the other faith communities of 1950s America occupied a specific position in the social landscape of post-war domestic life, and their relationship to the mental health of their members, and specifically to the postpartum mental health of the women in their congregations, is a dimension of this history that has received less attention than it deserves. The mainline Protestant churches, the Catholic parishes, the Jewish congregations that were a central organizing feature of suburban American life in the 1950s, were communities in the fullest sense. They were where families gathered and where social bonds were formed, and where the rituals of birth and marriage and death were performed with the full weight of communal witness. They were communities in which a new mother was visible, in a way she was sometimes not visible in the broader neighborhood, where the birth of a baby was announced and celebrated, and where the mother was, at least briefly, the object of communal attention and care. But these communities were also communities organized by specific theological and cultural frameworks about the meaning of motherhood and the appropriate emotional response to it, frameworks that were, in most cases, as thoroughly invested in the mythology of maternal fulfillment as the secular culture that surrounded them. The church that celebrated the baptism of a new baby was a church that understood the new mother's happiness as appropriate and her unhappiness as a spiritual problem to be addressed through prayer and pastoral counsel, rather than a medical problem to be addressed through clinical intervention. The pastoral role in addressing postpartum mental distress was significant, and in the majority of cases it was inadequate. The pastor or priest or rabbi who was called upon by a family concerned about a new mother's well-being was working within a framework that understood psychological suffering primarily as spiritual struggle, and whose primary therapeutic tools were prayer, biblical guidance, and the pastoral relationship that could provide comfort and community. These tools were not nothing. The pastoral relationship could provide a form of human presence and care that the medical system of the era often did not offer. Prayer and spiritual practice could provide a framework of meaning that helped women manage their suffering even when it did not cure it. The community that rallied around a family in crisis, bringing food and sitting with the children and providing the practical support that made daily life manageable, was doing something therapeutically valuable, even if it was not doing it under any clinical framework. But the pastoral response also carried risks that were specific to the religious framework within which it operated. The framework that understood maternal unhappiness as spiritual failure added to the already substantial burden of shame and self-reproach that the women we have been discussing were carrying. The woman who was told by her pastor that she needed to pray more, to trust more, to surrender her anxiety to God's care, was being given advice that was not clinically adequate, and that was organized around the assumption that the problem was spiritual rather than medical, an assumption that prevented the appropriate clinical intervention from being sought or recognized as appropriate. The stigma that mental illness carried in the 1950s secular culture was, if anything, more intense in the religious communities of the era, because the religious framework provided an additional layer of meaning for the failure of character that mental illness was understood to represent. The woman who broke down after childbirth in a religious community was a woman who had failed not only as a wife and mother, but as a person of faith, whose failure demonstrated insufficiency not only of character, but of spiritual standing. This additional layer of meaning added to her shame and complicated her ability to seek appropriate help, because seeking appropriate help required acknowledging that what she had was medical rather than spiritual, which was an acknowledgement that the religious framework made very difficult. There were exceptions. There were pastors and priests and rabbis who had the clinical awareness and the personal wisdom to recognize when a member of their congregation needed medical intervention rather than pastoral care, and who made referrals to appropriate clinical resources and who maintained the pastoral relationship alongside the clinical one. There were faith communities in which the stigma around mental illness was less absolute, in which the culture of care extended to people who were struggling psychologically, as well as people who were struggling in other ways. There were women of faith who found in their religious practice genuine resources for managing their postpartum distress, resources that worked not because they addressed the medical dimensions of the condition, but because they provided meaning and community and the specific comfort of a faith that said, "You are not alone in this, and what you are experiencing is part of what it means to be human, and there is a grace that holds you even in the places where you cannot hold yourself." These exceptions matter. The history of faith communities and postpartum mental health is not a history of uniform failure. It is a history of mixed responses, of communities that failed their members and communities that helped them, of individual pastoral figures who got it right, and individual pastoral figures who made things worse, of a relationship between religion and mental health that was as complicated and as variable as most relationships between large institutions and the specific needs of the specific human beings they served. But the dominant pattern was inadequacy, and the inadequacy was shaped by the specific theological and cultural frameworks that organized faith community responses to mental illness. The woman who brought her postpartum distress to her pastor in 1952 was, in the large majority of cases, bringing it to someone who was equipped to respond with pastoral care and not with clinical knowledge, and who was operating within a framework that made it difficult to recognize the clinical dimensions of what she was experiencing. The pastoral response she received was genuinely motivated by care for her welfare and genuinely inadequate to what that welfare required. The story of how faith communities have changed their responses to mental illness in the decades since the 1950s is a story that parallels, in the religious sphere, the story of how the broader culture has changed its responses. The development of pastoral counselling as a clinical specialty, the integration of mental health awareness into ministerial training, the development of mental health ministries in congregations that explicitly connect religious communities with clinical resources, and the slowly changing cultural attitude within many faith traditions toward the seeking of professional help for mental health conditions represent a genuine evolution in the relationship between religion and mental health in America. That evolution is incomplete. The stigma around mental illness in certain religious communities remains significant. The theological frameworks that understand psychological suffering as spiritual failure remain active in some traditions. But the direction of change has been toward a greater integration of clinical understanding into pastoral care, and toward a greater willingness to recognize that the resources of faith and the resources of medicine are not mutually exclusive, that a person can be both spiritually and medically cared for, and that the two forms of care address different and compatible dimensions of human need. The woman at the kitchen table in 1952 was not thinking about any of this. She was thinking about the baby and the coffee and the terror and the husband who would leave at 7:30. But the faith community she was part of, whatever it was part of the world that had formed her understanding of herself and her situation, and its absence from this account would have been a distortion of the reality it was attempting to describe. She believed, in the way that people of her era and her community believed, that God had given her this baby and this life, and that her unhappiness in this baby and this life was a spiritual problem whose solution lay in her own prayer and her own surrender and her own willingness to receive the grace that was supposed to be available to those who sought it. She had been seeking it. She had been praying in the small hours of the nights when she was not sleeping, in the specific and desperate way that people pray when they are frightened and nothing is working, and the only available next thing is to ask whatever might be listening to please help. She had not felt the help arrive. She had felt the terror and the distance and the cold coffee cup in her hands. She had not stopped believing. She had simply noticed, without yet having the words for what she noticed, that what was happening to her was more than prayer could address, and that the help she needed was a help that had not been specified in any of the available frameworks, and that the framework she needed had not yet been built. Recovery is not a single event. It is not the moment of discharge from the institution, or the morning you wake up and realize the terror has diminished to something manageable, or the first time you hold your baby and actually feel, something that resembles the love you were promised you would feel. It is all of these moments and none of them singularly, and it is also the accumulation of ordinary days in which the recovery happened not dramatically but incrementally, in the way that the light changes after the darkest hours of the night, slowly and almost imperceptibly until you realize at some point that it is morning and has been morning for a while. The women who recovered from postpartum depression in the 1950s recovered in the way that people recover from things when they have inadequate support, an incorrect clinical treatment, and no adequate name for what has happened to them. They recovered through the passage of time and through the specific resilience of the human organism that wants, when it can, to return to equilibrium, and through the relationships that held even when the relationships were difficult, and through the daily practice of continuing to inhabit the life they had been given, even when the inhabiting was very hard. This is a form of recovery that does not receive as much credit as it deserves. The recovery literature then and now tends to focus on the interventions that produce recovery: the right medication, the right therapy, the right clinical relationship, the right treatment plan followed by the right outcome. These interventions matter, and when they are available and adequate, they produce outcomes that are better than what the passage of time alone provides. But many of the women of the 1950s recovered without these interventions, in their absence, through the slower and less legible process of a human being finding its way back to itself through the ordinary materials of daily life. The specific materials of recovery for women of this era were the materials of the domestic life they had been returned to, the feeding of the baby that gradually over weeks and months became something more than a required task and began to be something that she was genuinely present for, a presence she could feel beginning to emerge from wherever it had been hiding. The baby that had been a source of terror and distance became, slowly and imperfectly, and not all at once, a specific person whom she was coming to know and who was coming to know her, and the relationship that built itself day by day in the feeding and the holding and the changing and the playing was a relationship that was building her recovery at the same time. The marriage that had survived the hospitalization, or that had not survived but had resumed in a modified form, provided another site of recovery, a relationship in which the ordinary negotiation of two people inhabiting a shared life was itself a form of re-engagement with the social world and with her own capacity for relationship. The conversations about ordinary things, the management of the household, the evenings watching the television programs that everyone was watching, the small arguments and the small reconciliations and the accumulated daily texture of a shared life, were all, in their way, the material of recovery. The neighbourhood and the women in it provided another site, the coffee clatches and the PTA meetings and the conversations over back fences that constituted the social fabric of the suburban community. She engaged with these in the careful way of someone who was not yet entirely confident in her own stability, who was managing her presentation with the particular care of a person who had something to conceal, but who was also, over time, finding in the ordinary social engagement of neighbourhood life a genuine sustenance. The faith, if it had sustained rather than burdened her, was another material of recovery, the prayer and the service and the community of the congregation providing a framework of meaning and belonging that the illness had not entirely destroyed, and that the recovery was rebuilding in its own way. And time. Time was the material of recovery that is easiest to underestimate because it is invisible in the way that constant things are invisible, and because it tends to be credited to the interventions that happened within it rather than to itself. But time was doing something. The hormonal system that had been disrupted by the peripartum period was restoring itself to equilibrium over the months after the delivery, and the neurological changes that had been part of the acute illness were resolving as the time passed, and the biology of the postpartum period did what it does when it is not too catastrophically disrupted. This was not nothing. This was, in many cases, the primary engine of recovery, with everything else, the institutional treatment and the relationships and the daily practice and the faith, serving as support for a process that was happening primarily because the body wanted to get well. The woman who was well enough in the months and years after the institutional episode to live her ordinary life was not necessarily the same woman who had sat at the kitchen table in 1952. She was older, and she had been through something, and the something had changed her in ways that were not all loss. Some women who came through the postpartum crisis of the 1950s described themselves afterward as having a form of knowledge they had not had before, a knowledge of the fragility of the self and the resilience of the self, a knowledge of what they were capable of enduring, a knowledge of the specific value of ordinary things that a person could only have by having experienced the loss of ordinary things. This knowledge was not worth the price that had been paid for it, but it was there and it was theirs, and some of them drew on it for the rest of their lives. Some of them became, quietly and without any official recognition, the women in the neighbourhood who knew what to do when another woman was struggling in the particular way they had struggled. They did not use clinical language because they did not have it. They used the language of women who had been there. The particular, knowing that, is available only to people who have been where you are and who can see, in the quality of your distress, the thing they recognise from their own experience. They sat at the kitchen table with the struggling woman, and they did not tell her she was fine, and they did not tell her to pray more, and they did not tell her that she should feel grateful. They sat there, and they let her be not fine, and in the letting her be not fine they were providing something that the medicine of their era, and the culture of their era, and the religion of their era could not provide. The recognition that what she was going through was real, and that someone else had been through it, and that she was not uniquely failing at the most important thing she had ever been asked to do. This is not a clinical intervention. It is not a named therapeutic modality. But it was happening in kitchens across America in the 1950s and 1960s and beyond, woman to woman, in the quiet way that care moves between people when the official systems have failed, and what remains is the simple human willingness to sit with someone in the dark and stay until the light comes. The light comes. This is the thing that the history of recovery in all its imperfect and incomplete and various forms consistently establishes, not quickly and not reliably, and not the same for every person and not without cost, but it comes. The morning that arrives in the ward after the longest institutional night is still morning. The first day at home with the baby when she feels something genuinely warm in her chest, when he looks at her, is still the first day, even if it comes weeks later than it was supposed to, and in a different form than the books promised. The morning when she wakes up and lies in the ordinary dark of the bedroom and realises that the terror has been quiet for several days, that she has not noticed it, which means she was not listening for it, which means she was thinking about other things, which means she's getting well. That morning is still a morning. It is enough, imperfect and hard-won and not what she deserved, but real. The light comes. It is late in this story as in the hour, and the house in the middle of the American century has grown quiet. The baby that was 6 weeks old in the opening of this account is 40 years old now, or 60 years old, or has children of its own who do not know the specific thing that happened in the early months of its parent's life. The woman who sat at the kitchen table with the cold coffee has aged through the decades, and carries what happened in whatever way the long years have made possible to carry it. The history of how postpartum depression was treated in the asylums and the private sanitariums, and the psychiatric wards of general hospitals, and in the domestic silence of homes where it was never acknowledged, is a history that makes demands on how we understand the relationship between medicine and culture. It makes the argument, in the specific form of documented human suffering, that clinical practice is not separable from the cultural frameworks within which it is delivered. That when those frameworks tell medicine that women's postpartum suffering is a failure of character, rather than a medical event with a biological basis, the medicine that follows will reflect that understanding and will cause harms that flow directly from it. The treatments administered in good faith to women who were misdiagnosed and inadequately supported were administered by people who believed they were helping. The harm they caused was real, regardless of the intent. The framework that made the treatment possible was the framework that made the harm inevitable. The women who were hospitalized in these institutions, who were subjected to these treatments, who were separated from their babies and their homes and their lives for months or years, while the institutions decided they were well, came out the other side different from how they went in. Some were helped in specific ways, their acute symptoms reduced, their most severe presentations addressed enough to allow them to function. Some were harmed in specific ways, their memories disrupted, their relationships damaged, their capacity for the trust that health requires, diminished by the experience of having had all authority over their own lives removed. All of them came out into a world that did not acknowledge what had happened to them as something that warranted acknowledgement. A world that had organized itself to be unchanged by their experience and to require them to be unchanged in all the ways that mattered. What we carry from this history is several things simultaneously. We carry the grief that is appropriate when we look honestly at what was done to people in the name of helping them, the grief that attends the gap between the intentions of an era and the consequences of its actions. We carry the recognition that this is not only the past but the ongoing character of medical practice, that every era delivers care within frameworks that it cannot fully see, and that will look different from the perspective of the era that follows. We carry the obligation that this recognition produces, which is to look at the frameworks of our own time with something like the critical attention that hindsight brings to the frameworks of other times, to ask what we are assuming that we cannot yet see, whose suffering is being organized into a category that prevents it from being adequately addressed. And we carry, alongside all of this, something that is not grief and not obligation, but something more like respect. Respect for the women who were in these institutions and who managed, in whatever way managing was possible, to remain themselves inside conditions designed to strip them of themselves, who found in the friendships of the ward or in the letters they wrote and sometimes burned, or in the occasional human connection with a decent nurse or an occupational therapist who treated them as people, the small threads of selfhood that kept them tethered to who they were, who came home to babies who did not know them and households that had organized around their absence and rebuilt those relationships with the patience and the care that the situations required, who lived, most of them, their ordinary lives afterward, not because the ordinary life was all that could have been hoped for, but because the ordinary life was what was available, and they were determined to inhabit it fully. The baby in the crib is sleeping. Somewhere tonight a new mother is awake in the house that is quiet, listening to the breathing of an infant in the next room, present in every required way, and struggling in ways that may or may not yet have a name in her understanding. She lives in a world that is better than the world of 1952 in ways that are real and significant. She also lives in a world that is not yet adequate to what she needs. The story is not finished. The work is not done. The names that exist now are not the end of it. They are the beginning of the part that the women of the 1950s were not alive to see, and that the women of the present have the obligation to continue. Rest now. The kitchen is quiet. The street outside the yellow curtains is pale in the early morning. The baby is breathing in the next room, the soft and even breath of a sleeping child, and it is the most important sound in the world. It is the sound she has been listening for through all the weeks in the institution, and all the nights of recovery and all the mornings that came after the hardest nights. She can hear it now. She is here. She is home. Let the story settle in the quiet. Let the long arc of it, from the unnamed terror of 1952 to the partial and imperfect present, in which some women have the name and some do not, and the work continues, hold its full weight, and then release it. Let the women who are there and who are gone now be remembered with the specific dignity that their specific lives required. Let the women who are here now, in the middle of their own early mornings with their own cold coffee and their own babies quiet at last, know that they are seen. The work continues, the light comes. These two things are both true, and holding them together is the only adequate response to the history this story has been tracing. Sleep if you can. The morning will come when the morning comes. Thank you so much for watching. If you would like to see more videos like this, please consider leaving a like and subscribing to the channel, as it really helps us continue making more content. Anyways, see you in the next one. What surprised you most about how postpartum depression was treated in mid-20th century asylums and psychiatric hospitals? Were you aware of how much legal authority husbands held over their wives' psychiatric care in the 1950s? And what do you think of the hard-won progress that has been made in the decades since? Leave your thoughts in the comments below. A note on the sources that have informed this account. The history of postpartum psychiatric care in the United States draws on the institutional records of the state hospital system. The clinical literature of the period from the Journal of Mental Science and the American Journal of Psychiatry, the sociological work of Irving Goffman and others who documented the total institution, the oral histories collected by researchers and documentary makers, the literary accounts of Sylvia Plath and Anne Sexton, and subsequent memoirists, the advocacy literature of the feminist health movement, the clinical research that produced the Edinburgh Postnatal Depression Scale and the evidence base for contemporary treatment, and the testimony of women who experienced what this account describes and who have, over the subsequent decades, found the words for it. Their words matter. Their experience matters. The history they made possible, by surviving and by speaking when speaking was possible, and by refusing the silence when the silence was no longer the only option, is the history that allows us to sit with this story in the quiet of an evening and understand it as what it was and what it means and why it demands that the work continue.